Oh my God, that was the last meeting. We have a physical meeting here in Dubai. That was 1 month before COVID started. It was 2020 of February. Bismillah ar-Rahman ar-Rahim. Good evening, Gulf region and Far East. Good afternoon, Europe, and good morning, USA. On behalf of my co-director, Dr. Krager, and myself, I would like to welcome you to the special edition of 40S, tap-to-toe transcatheter solution, on the latest interventional advances in heart failure. My name is Omar Halak, and I'm interventional cardiologist and head of cardiovascular department at King's College Hospital, Dubai. In the past, I thought heart failure was kind of boring subject for interventionalists, but with the latest advancement and so much involvement of the interventionalists in the treatment of heart failure, it became one of the most interesting diseases to manage. Of course, we know that revascularization for ischemic cardiomyopathy, but there is much more in the heart failure management, including transendocardial injection of FGF stem cell, transvenous, transarterial injection also of those special treatment, and there's much more for the heart failure management by interventionalists and cardiac surgeon. Today, we will learn the latest in the treatment of heart failure. Also, we'll have some talk about hibernating myocardium, the latest medical treatment outcome, angiogenesis for heart failure, stem cell therapy for heart failure, left assist device, the latest in that subject, also electrophysiology intervention for heart failure. We're going to talk all the way up to the heart transplant, the latest in the heart transplant, and artificial heart. So I hope this meeting will be informative or enjoyable, and we have a really very selected, renowned speaker from around the world. Most of the speakers actually from USA, Texas Heart, and Baylor University, and St. Luke Hospital. This symposium is kind of a sampling of the original conference. It's usually take place in February. The coming one will be 10 to 12 February 2022. We are not sure yet it's going to be virtual or physical or hybrid, but we'll take it day by day and see what happens. In that meeting, we'll have 4 parallel sessions, and every session have either vascular intervention, structural intervention, and other endovascular intervention. And then will be some other for general cardiology and the latest advancement of general cardiology. We expect that the meeting will be for 3 days, and we expect more than 5,000 people to attend. Thank you.
Thank you, Omar.
I'd like to have Dr. Krager to also welcome you, the co-director.
Thank you for this introduction. We met almost more than 8 years ago, Omar, in Dubai, where we envisioned how to design and bring to fruition 4Ts, or from top to toe transcatheter solutions. And it has been an enjoyable partnership that we have established over a period of years. So I would like to mention that this educational event is endorsed by several leading societies, including the International Society of Endovascular Specialists, where I was immediate past president. And also I represent Texas Heart Institute and Baylor CHI Medical Center in Houston, Texas. As you will see, a great number of presenters today will be from our institutions. So joining this meeting is a group of truly internationally renowned experts in the field of heart failure, as you will see, to present the latest advances on this topic. Thank you, Omar, for making this event happen, and we are certainly looking forward and hope that Fortis 2022 will become a reality, not only virtual, but true reality.
We're looking forward to see you in Dubai and all the faculties and all the attendees for that matter. Thank you very much for being with us. You've been having great support from the day one we met, and we talk about this meeting, and you have been all along with great support. Thank you so much.
It is my pleasure. Now, without further ado, I would like to introduce the first speaker for this meeting. And the first speaker is the organizer and program director, Dr. Omar Halak, and he will talk on hibernating myocardium.
Hi, my name is Omar Halak. I'm an interventional cardiologist and the head of cardiovascular department at King's College Hospital, Dubai. My talk today about hibernating myocardium and heart failure. As we know that heart failure is a really very common problem worldwide. Estimated about 64 million people around the world with diagnosis of heart failure. The most common reason for heart failure is ischemic heart disease. About 70% of the causes is ischemic heart disease. What is hibernating myocardium? It's a chronic myocardial contractile dysfunction due to ischemia with reduced coronary blood flow at rest. It is in which ischemic cells remain viable. Contraction can be partially or even totally restored by improving the coronary blood flow. The term reawakening of myocardium after restoration of the blood flow was described in 1978 by Dr. Diamond and subsequently by Dr. Rahmatullah and Dr. Bronwald and Rutherford. They emphasize on the need of identification of this entity and revascularization. The problem can be regional or can be global. How about stunned myocardium? Stunned myocardium is a myocardium have suffered of transient myocardial contractile dysfunction induced by acute ischemia, where there is total occlusion of the blood supply for about 5 to 15 minutes. So that area become hypocontractile or acontractile, and that thing lasted for several days. How about non-viable myocardium or scarred myocardium? This is a problem when there is ischemia by complete occlusion of the blood supply to the area was long enough to cause permanent damage of the myocardial cell. And restoration of the blood flow will not reverse this akinesis because of the cells are dead. Similar to if you have a flower or rose and did not have water for a long time and it become dead, putting water on it not going to make any difference. Now back to the flowers. The first one on the left is a normal perfusion, normal watered flowers or normal perfusion to the myocardium. If there is lack of ischemia, of course it'll be wilted flower and it'll be hibernating myocardium. So it's still alive, but not really functioning properly. Now, if the ischemia was completed and for a long time enough to cause permanent damage and death of the cells, then this is not reversible, not irreversible damage, and reperfusion will not cause any benefit to the myocardium. However, if there is hibernating myocardium, reperfusion is bring back to close to normal or normal function of the myocardium. So what is the treatment of heart failure with viable myocardium, hibernating myocardium? Of course, as I mentioned, the key treatment is reperfusion. So reperfusion bring back the hibernating cells to a fully functioning cells and back to normal function. How to find out which patients will benefit from reperfusion? Basically, to find out which patient have a viable myocardium, but that segment is not working, is not contracting. As is by finding the myocardium that contract if stimulated, or the existence of metabolic activities in dysfunctional segment. Then to check that out, do an echocardiogram or cardiac MRI. If the wall thickness less than 5 millimeters, the probability of improvement is less than 5%. Most likely that it is scarred, dead myocardial cell, and not likely to improve after revascularization. However, if the thickness more than 6 millimeters, there is a probability of improvement more than 50%. Then you can do low-dose dobutamine or SPECT scan, and if dobutamine showed viable myocardium, so with a low-dose dobutamine, the hypocontractile segment become more contracting, and so that is still viable. Of course, if we increase the dosage of dobutamine, it becomes ischemic afterward and be back to akinetic. So that's called biphasic response with dobutamine. So if the test was positive for viability, so probably revascularization will benefit the patient. If the initial test shows non-viable myocardium, you may consider cardiac MRI or PET scan if there is less than 50% of hyper enhancement or there is mismatch. So that means the myocardial cell is still alive, then revascularization may be benefit. Some data on this. This is a diagram from Dr. Rahmatullah from 2006. He is showing here this patient had occluded LAD proximally, and as you can see, this is diastole and this is systole, and there's not much activity going during systole, and ejection fraction 37%. Patient underwent Lima to LAD, and after a few months, 8 months, the contraction, this is the diastole and this is the systole, back to normal contraction, and ejection fraction went to 76%. This is a study of 3,000 patients with ejection fraction about 32%. They were 35% of those patients revascularized, and 65% went to medical therapy. And if you can see here, the patients who have viable myocardium and revascularized have very low mortality rate. However, the one who have viable myocardium and did not revascularize, they have about 3 times or 4 times, more than 4 times mortality rate. So there was about almost 80% reduction of the mortality for after revascularization of viable myocardium. However, if the myocardium is not viable, so there's not really much difference between revascularization or medical therapy. How about ischemic heart failure with viable myocardium, but we don't have target vessel for revascularization? Like this patient doesn't have really much target to revascularize. Anything that can be done? Well, can we induce a new blood vessel in this area to restore the perfusion? And the answer is yes, it is possible to induce formation of a new blood vessel in the ischemic area. The idea came from a healing process of injury. When you have injury anywhere in the body, in the arm or anywhere in the body, so the way the healing process started is apparently there is some hormonal and other transmitters stimulate creation of a new blood vessel, get to the damaged area, and that bring the blood supply and start the healing process. Also, we know that patients who have a cancer, the cancer cells secrete some stimulant, and that stimulant creates some blood vessel to feed that cancer. And so it's kind of some stimulant to the blood vessel, it get there and start to create a new blood vessel, and the blood vessel start to grow and have endothelium in there and start to get a blood supply to that area. Many of those transmitters were identified such as FGF and others. So that is called the angiogenesis. And so there was a lot of trial to confirm this theory of injecting a stimulant, FGF, in the ischemic area and to show a growth of a new blood vessel in the area. To give an idea how much active research in this area in the last few years, you just put search for angiogenesis in ischemic heart, and you end up with 43,000 articles. So there is a huge amount of work has been done in this subject of angiogenesis, and there is a lot of promising result of those studies. We're going to have a lecture during this symposium about angiogenesis for the heart failure. Another question, how about if the heart failure patient have non-viable myocardium? So just doing revascularization may not going to be beneficial. That idea coming from implanting some cell in the damaged myocardium, and those cells, hopefully it will differentiate it into myocardial cell and start to contract. And that's the theory of stem cell therapy. And so some of the cell will be grafted in the myocardial area and differentiated to replace the diseased cells. Some other things can be done by paracrine effect, which stimulated the stimulating factor for the patient's own cell to repair the damaged tissue. This is a very exciting field. And again, if you research stem cell treatment for heart failure, you end up with 75,000 articles. So you can imagine how much work has been going on the stem cell therapy for the heart failure. So this is angiogenesis and stem cell is very exciting field of treating heart failure. Of course, there is a lot of other treatment, device treatment, surgical treatment. It's of course in this symposium we're going to hear a lot of those latest advancement of the heart failure management, and we have a special talk on stem cell therapy for the heart failure. How to get the stem cell to the heart? It can be through the arterial intracoronary, or it can be intravenous. It can be transmuscular, intramuscular transendocardial injection, or direct injection to the myocardium, or it can be a 3D fibrin scaffold. So it's a very similar way of giving also the FGF for reducing blood vessel, for the stem cell for reducing the new myocardial cell. In summary, heart failure is a common disease with bad outcome. Rapid development with the new medical treatment have a good result. For ischemic heart, probably the best treatment is reperfusion. Lot of exciting work on angiogenesis, stem cell, in addition to device therapy and much more, which you're going to hear in this symposium tonight. Thank you.
Thank you, Omar, on this very interesting introductory presentation on hibernating myocardium and what has been done and what can be done to treat heart failure, and advances related to this particular topic. We will certainly hear quite a bit more in detail by the following speakers on this particular topic. But now let's go a little bit back to where it all started with William Withering way back there, several centuries back. What does medical treatment of heart failure offer? And talk about the latest advances in this particular field and what are the unmet needs. I don't think that anybody is better equipped and has the greater expertise than the next speaker, which is Joseph Rogers from Texas Heart Institute. He is the latest addition to our institution, the Texas Heart Institute. He is the president and CEO of Texas Heart Institute. He came to our institution roughly 4 months ago. And Dr. Rogers has been a leader and participant in many, many clinical trials related to heart failure. So without any further ado, I would like to introduce Dr. Rogers to present the information on the latest advances in pharmacotherapy of congestive heart failure. Joe?
Good day, everyone, and thank you for joining this symposium. I'm Joe Rogers, and I'm the president and CEO of the Texas Heart Institute, and have been asked to give some comments on the latest advances in heart failure pharmacotherapy. I'd like to thank the organizers of the conference for this kind invitation. It'll be no surprise to this audience that the prevalence of heart failure is really a global issue for us, and as you scan across this figure, you can see that the estimated prevalence of heart failure, regardless of the area of the world, is somewhere between about 2 and 5%. There are some interesting demographic changes that are occurring, with some areas of the world having an increasing incidence of heart failure in younger patients, while in other parts of the world that incidence is decreasing. But regardless, this remains a global challenge for all of us practicing cardiovascular care across the world. Earlier this year, there was a consensus paper that was put out by the American College of Cardiology re-examining and re-stratifying heart failure pharmacotherapy based on current evidence. And I think that this is a particularly useful figure for all of us who are seeing patients on a day-to-day basis to help us frame out an appropriate approach that's evidence-based to the management of these patients. In this particular guidance piece, you can see this is really focused on patients who have heart failure with reduced ejection fraction who have symptoms. And you can see that the current evidence would suggest that we start with either an ARNI, an ACE inhibitor, or ARB, and the data actually would support the use of an ARNI. With additional therapies shown below, which could include aldosterone antagonists, the SGLT2 inhibitors, diuretics for patients who are volume overloaded, hydralazine and nitrates in specific patient populations, and potentially the addition of ivabradine for patients who remain tachycardic on beta blockade. But the challenge, I think, for many of us who are practicing is that it's becoming confusing about the way in which we may add these different therapies, and I'll come back to that in just a second. I think one of the more exciting advances in the last several years has been the observation that the SGLT2 inhibitors have a profound impact on heart failure outcomes. And this was originally seen in diabetes trials, but more recently, we've begun to test this hypothesis in heart failure patients who don't have diabetes. The mechanism of the way these drugs work in our heart failure population is not entirely clear, but what you can see on the left side of the slide are the potential mechanisms for why SGLT2 inhibitors may improve outcomes in heart failure, and I won't walk through all of them. On the top side of this, the right side of the slide, I think what you'll appreciate from the diabetes trials were these important reductions in risk, in cardiovascular risks and in cardiovascular outcomes in patients who were treated with the SGLT2 inhibitors. And as this audience knows, the more recently performed EMPEROR series of clinical trials has demonstrated improvements in outcomes in heart failure patients. And in the bottom of this slide, this is some data from the EMPEROR reduced trial in a heart failure population that was well treated at baseline, randomizing patients to either empagliflozin or placebo. And what I think you will be able to appreciate is that the patients who were randomized to empagliflozin had a 25% reduction in their risk of cardiovascular events and mortality over the span of a couple of years. So how do practicing cardiologists begin to think about staging these therapies? On the left side of this slide, you can see the conventional way, I think, that we've all learned how to do this, where we start with a drug that blocks the renin-angiotensin system, then add a beta blocker, then add a mineralocorticoid receptor antagonist, etc. But Packer and McMurray have suggested a different kind of approach, which is shown on the right side of this slide, which can be accomplished in the span of approximately a month, where you start off with a beta blocker and an SGLT2 inhibitor, and then over the span of the next couple of weeks, add an MRA, add an ARNI, and then subsequently add an MRA. And I think what you can appreciate is even though you may not get to target doses of drugs, and that can be done in the ensuing months, this is a great way to get patients on an evidence-based approach with subsequent titration in the months to follow. I wanted to turn to the other group of heart failure patients, the 50% that don't have reduced ejection fraction, and review where we are today. This is some older guideline recommendations from the American Heart Association and the American College of Cardiology, which are very, very fundamental and I think highlight where we are today with heart failure pharmacotherapy for the HFpEF population. But you can see that really the only two recommendations that had a level of recommendations category 1 were blood pressure control and the use of diuretics to maintain a euvolemic state. But I wanted to review a couple of advances that I think were important. One was some data from the TOPCAT trial, a trial of HFpEF patients randomized to either spironolactone or placebo. And you'll remember in the primary analysis of that data, there was no difference in outcomes between the patients randomized to spironolactone or placebo. On the other hand, a sub-analysis of this trial, I think, provides some other important insights. Recall that in that trial, which was a global trial, there was a secondary analysis that looked at patients who were enrolled in Russia and in the country of Georgia and compared them to the patients enrolled in the Americas. And I think it's based on this that you begin to see some very striking differences in outcomes. The patients enrolled in the Russian parts of the world, first of all, had a much lower mortality rate, and the drug was ineffective in that patient population, whereas in the Americas, the mortality rate was much higher and more consistent with the reports of mortality outcomes in this patient population. And in that population, the drug seemed to have a favorable effect. So I think the way that many of us are interpreting this information is that if you're truly enrolling patients who have heart failure with preserved ejection fraction, spironolactone may provide an advantage. And then I wanted to highlight one additional trial, which was presented yesterday, but in the future because we're recording this a week ahead of time, the Emperor Preserve trial, which was testing the role of empagliflozin in a HFpEF population, 6,000 patients with symptomatic heart failure whose ejection fractions were greater than 40%, and they had to have elevated NT-proBNPs. And they were randomized to either empagliflozin or placebo. And what we know about this 1 week ahead of presentation at the ESC is that the result is positive. So by the time you're watching this, we should have some indication about the outcomes from Emperor Preserved. So to summarize and conclude this part of the presentation, we've talked a little bit about this multi-drug regimen for HFrEF. And certainly what we've recognized is that the compelling evidence for the ARNIs have led to them being replaced, led to them replacing the ACE inhibitors and ARBs, and that SGLT2 inhibitors are now indicated based upon the positive data from the clinical trials. We've got no prospective data that looks at some of the ways that we should be staging these therapies, but go back and remember that chart I showed you about starting patients on an SGLT2 inhibitor and a beta blocker, and then rapidly and sequentially adding an ARNI and then subsequently an MRA to improve patients' outcomes. Spironolactone may be beneficial in that HFpEF population when used in appropriate patients, and I think we should watch closely to see what the results of the Emperor Preserve trial show at ESC. I didn't have time to talk to you about the roles for omecamtiv and vericiguat. Those trials both shown to be positive in the last couple of years. I think we're trying to understand the patient populations that might benefit the most from those. And finally, consider the use of tafamidis in patients with TTR amyloid that have cardiac manifestations. So again, I want to thank the organizers of the symposium for the kind invitation to participate, and I'll look forward to our discussion. Good day, everyone, and thank you.
Well, that was a great presentation. Thank you so much. It was really great, up-to-date management of heart failure. This is a very kind of fast developing case where we have a new information every day. It was greatly presented. Thank you so much for the presentation. Next speaker will be Dr. Jack Jacob. He's going to talk about the angiogenesis, a potential treatment for ischemic heart failure. Dr. Jack Jacob is the president of Zetia company who kind of inventing and working on angiogenesis treatment.
Hello, this is Dr. Jack Jacobs. The title of my talk is Angiogenesis, a potential treatment for heart failure. In today's talk, I'll review clinical trials in which we've injected an angiogenic growth factor into the hearts of patients with no option heart disease. I'll then move towards the end of my talk to talk about how we're going to combine this angiogenesis growth factor therapy with stem cell therapy to treat patients with ischemic, chronic ischemic heart failure with reduced ejection fraction. Let me just review what angiogenesis is. It's a natural process in our body. This shows angiogenesis in a wound bed. This is our growth factor, which I'll talk about in a second, stimulating the growth of new blood vessels in this area of a wound. And we see the same activity when we inject this into the ischemic heart tissue. The growth factor we're using is FGF1, fibroblast growth factor 1. Three-dimensional structure shown here. I actually was involved in purifying this a number of years ago from CalBrains. And what distinguishes FGF1 from all the other angiogenic growth factors is that it can potently stimulate both small vessels, capillaries, angiogenesis, but also importantly, growth of small arteries or arteriogenesis. And this is through its ability to be a mitogen for both endothelial cells and smooth muscle cells. The process of angiogenesis is shown in this slide. FGF1 shown here, binding to the FGF1 receptor on blood vessels. Endothelial cells become activated. They begin proliferating. And here we have the formation of a tube, a brand new capillary growing into the wounded area, bringing blood perfusion to wounded areas. We see this the same exact process ongoing in the heart. Now, very importantly, the FGF1 receptor is upregulated over time. So let's say in the heart, we go from healthy to ischemic heart disease. And over time, these FGF1 receptors get greatly upregulated, 10 to 100-fold. So this gives us a really nice safety margin. You inject FGF1 into healthy heart tissue, you're not going to see any angiogenesis response, but you get a robust angiogenesis response when you inject this into ischemic heart tissue. Now, 3 separate clinical trials have shown the ability of FGF1 to stimulate angiogenesis in patients with severe heart disease. These are patients that can't have a bypass or stent put in. Let me show you that data, and then I'll move on to the clinical trial we'll be doing in heart failure patients. Here's the first clinical trial. It was done, the FGF1 was used as adjunct therapies in patients undergoing revascularization. And so the FGF1 was injected into distal areas which weren't being revascularized. And you can see here, this is after 12 weeks after injection of FGF1. You see this blush work of new vasculature in the heart where FGF1 was injected. These new blood vessels persisted for at least 3 years. So here's 3 months. This is capillary density in the area that was injected in the ischemic heart with FGF1. You can see here, after 3 months, this enhancement of capillary density. And this same enhancement is visible 3 years by angiography in these same patients. In the second clinical trial, FGF1 was used as a sole therapy, so not in conjunction with the bypass. In those patients, we saw a highly significant improvement in exercise performance preoperatively, and then this is 45 days, 90 days after treatment with FGF1. Statistically significant improvement in exercise performance. We also saw increased cardiac perfusion. This is by SPEC, preoperatively, rest and stress. Nice improvement in cardiac perfusion at both rest and stress. This is graphically shown. A highly significant improvement in stress SPEC after 90 days. Let's move to the third clinical study. This again was a sole therapy trial. This is a trial that I supervised. We had 6 US sites. Again, people with no option patients, no option heart disease patients, getting FGF1 injected into their hearts as sole therapy. Actually, ABC News went to one of our clinical trial sites to interview the cardiologist and some of the patients. Let me just show you that news clip. It runs for a minute, and I'll come back after that.
But since receiving an experimental treatment for his blocked arteries, his pain is gone.
I really feel great.
Duke was one of the first heart patients in the country to be treated with a protein actually capable of growing brand new arteries. The genetically engineered protein is injected directly into the heart. Within days, a network of new vessels begins to grow around the blockage, increasing the blood supply. Dr. Lynn Wagner showed us the changes in one patient's heart.
We see a small, narrow main artery and not very many secondary and tertiary arteries. This is after the treatment. What we're now seeing is new blood vessels growing here off the end of this artery.
And the patients themselves?
Symptomatically, they're improved within a couple of weeks of the treatment.
Just ask Constance Donnelly.
Oh, I feel wonderful. I've never felt so good in the last 5 years.
But doctors already see potential in other cases where the blood supply needs a boost, such as strokes and diabetes.
So let's look at the summary data from that clinical trial. We treated 32 patients, 3 ascending doses. This shows the summary scores for angina scores. So before treatment of FGF1, all the patients were class 4 severe angina or class 3. 12 weeks after FGF1 was injected into their hearts, we see a dramatic improvement in angina scores to class 1 and to class 2. Again, in that summary data from that phase 1 clinical trial, pre-treatment, post-treatment, this is exercise, treadmill testing, again, a significant improvement in their exercise treadmill testing. So let's talk now about our 4th planned clinical trial. We'll be using sole therapy with FGF1 to induce angiogenesis in patients that have chronic ischemic heart failure with reduced ejection fraction. So the first phase of this treatment will be induction of angiogenesis with FGF1. And we'll be using a catheter injection system to inject about 20 areas in the heart that show ischemia. We'll be using a cardiac injection catheter to inject both the FGF1 and then the stem cells 3 months later. So this injection catheter can be precisely aligned with ischemic areas of the heart. And we're going to identify ischemic regions of the heart using cardiac perfusion MRI with delayed gadolinium enhancement. This just shows the power of this technique. Here's SPEC imaging of the ischemic heart. With the gadolinium enhancement, you can very clearly see areas of ischemia that aren't apparent by SPEC, and these areas of ischemia can be confirmed with histological analysis of heart tissue. This again shows the ability of gadolinium enhancement to very easily differentiate between normal heart tissue, ischemic heart tissue, and infarcted heart tissue. So the design of this phase 1 clinical trial, again, will mainly be for safety, but we'll be collaborating with researchers at Stanford University who have done previous trials with these mesenchymal stem cells. So from the same patient, stem cells are harvested from the patient's marrow. They're then, through gradient centrifugation, the mesenchymal stem cells are enriched using a cell sorting technology. They're enriched for the CD 105 plus marker for mesenchymal stem cells. And using that same, not this needle, but a cardiac injection catheter, we will then inject the stem cells into those areas of the heart that had been previously injected with FGF1. So we're using a combination of this angiogenesis cell biological growth factor therapy coupled with stem cell therapy. So we'll follow these patients for a year. This is mainly a phase 1 safety trial, but we're going to be looking also at ejection fraction scores, exercise improvement, and also cardiac perfusion with that MRI technology. For more information on this clinical trial, you can go to our website, zgm.care. You can actually sign up for these clinical trials at this website. So I thank you for your attention, and that is the end of my talk.
All right, Dr. Jacobs, what a wonderful presentation. We thank you so much for that very timely information. And we want to keep moving forward. So I want to introduce the next speaker, Dr. Zvonimir Krejcir, hailing from the Texas Heart Institute. Now, I get the pleasure of introducing him to all of you all around the world because he's my professor and a great dear friend, wonderful man that has accomplished so much in his career, and the father of the 4TS, as well as the father of the International Society of Endovascular Specialists. And thank you, Dr. Omar, for having him be here to present to us.
Pleasure to have him always.
So the pertinent facts about congestive heart failure and cardiorenal syndrome. Take it away, Dr. Krejcir.
Thank you, Dr. Hollick. The topic of this presentation is cardiorenal syndrome, current concepts, treatment options, and outcomes. Cardiorenal syndrome encompasses a spectrum of disorders that involves both heart and kidneys, in which acute or chronic dysfunction or conditions in one organ can affect the function of the other organ. So we are familiar with cardiorenal syndrome, where either acute or chronic cardiac condition affect renal function, but it's less known or less popular that there's also renal cardiac syndrome, where many renal conditions, either acute or chronic, can affect cardiac function. What are the pathways that exacerbate cardiac or renal dysfunction? As we can see here, it's a very complex interaction between two organs, and one of the most common factors that play a significant role is hemodynamic alterations, either acute or chronic. As far as cardiac function is concerned, it could be due to ischemia, cardiomyopathy, arrhythmias, valvular disease, and so on, that affect cardiac output or decrease the blood pressure, and that eventually causes dysfunction in the renal vessels and decrease renal function. But there are also non-hemodynamic factors that play a significant role, such as neural, affecting CNS system, either via vagal stimulation or via sympathetic stimulation, that can cause also vasoconstriction and other issues related to renal function. There's also imbalance as far as oxygen and nitric oxide production, as well as several humoral factors such as persistent renin-angiotensin-aldosterone system activation that plays a significant role as far as renal dysfunction is concerned. And more recently, we have learned that there are many inflammatory factors that play a significant role in this dysfunction, such as elevated levels of tissue necrotic factor alpha, interleukin-1, and also interleukin-6. So what is the classification of cardiorenal syndrome? There are 5 types, as is shown here. This has been described clearly by American Heart Association Council on the Kidney and Cardiovascular Diseases and Council on Clinical Cardiology, and published in Circulation in 2019. The most common one and the most familiar to us is type 1 cardiorenal syndrome, which is acute cardiorenal syndrome, where heart failure results in acute kidney injury. Type 2 cardiorenal syndrome is a chronic cardiorenal syndrome where chronic heart failure due to many causes affects kidney function. And then there is a type 3 cardiorenal syndrome where acute renal cardiac syndrome, such as kidney dysfunction, results in acute heart failure. Type 4 cardiorenal syndrome is chronic renal cardiac syndrome where chronic renal disease results in cardiac dysfunction. And finally, type 5 cardiorenal syndrome is what we call secondary cardiorenal syndrome, where systemic factors or processes result in heart failure and renal failure. This is like typically seen in conditions such as amyloidosis, septicemia, cirrhosis, and so on. Cardiorenal syndrome type 1 is the highest risk factor for death. So what are the facts about acute decompensated heart failure and cardiorenal syndrome? Well, approximately 1.8 million patients annually are admitted in the United States with a diagnosis of acute decompensated heart failure. And approximately 150,000 patients are annually admitted with a diagnosis of cardiorenal syndrome. And I believe that this number is very conservative, and I believe a significantly larger number of patients actually have this condition. Now, it's also important to know that renal insufficiency occurs in more than a third of patients with acute and chronic heart failure. And patients with cardiorenal syndrome have a 20-fold increase in in-hospital mortality over patients with normal renal function. Now, diuretics are the mainstay of therapy for those conditions, but we have learned from a variety of clinical trials that between 15 to 20% of all heart failure patients develop diuretic resistance. And this condition is also associated with increased length of stay in the hospital, many complications, and increased costs. Now, there have been many medical trials carried on using a variety of different drugs to correct and treat this problem. One of the earlier ones, in addition to diuretics, was the use of ACE inhibitors. And as we can see here, and also in many other trials, no significant improvement was achieved in the outcomes. Similar findings occurred with the use of ARBs as far as outcomes are concerned, and no significant improvement has been identified. Treatment with mineralocorticoid antagonists also have shown failure as far as outcomes are concerned. And similar things were identified as far as treatment of fluid overload is concerned with ultrafiltration in patients with acute decompensated heart failure, no significant improvement in patient outcomes. So in summary of the clinical trials related to acute decompensated heart failure and chronic renal failure is concerned, more than 24 failed drug clinical trials have been carried on, and this goes on and on and on. So obviously this condition is the biggest unmet need as far as patients with heart failure is concerned and cardiorenal syndrome is concerned. Therefore, we need a mechanical solution to this problem. And we know as far as today's temporary percutaneous support devices that are used, they include ECMO, tandem heart, Impella, and one of the older ones, intra-aortic balloon pump, and Centrimeg. Those devices are useful and being used on a frequent basis. However, they carry certain potential complications and add, as far as complexities are concerned, for treatment of heart failure and cardiorenal syndrome is concerned. There was therefore a need for newer percutaneous devices for treatment of those conditions. And here I have listed some of them that are currently being investigated in the United States and also abroad, such as the RIA catheter, TRVD by Magenta, precardia with a Biomed CardioBridge, Aortix, second heart assist device, CPNS, and Reprieve device. We can see some of them were placed in infrarenal, some of them were placed in supra-infrarenal aorta, and some of them are, such as CardioBridge, Aortix, a second assist device, placed in descending thoracic aorta with the purpose of improving cardiac function and also directly increasing the renal flow. One of the earliest of those devices that are placed in the descending thoracic aorta is a Raytan CardioBridge device that is shown here. It's a 10 French catheter device that's placed percutaneously, and it has an impeller. And this device has shown encouraging preliminary result. Another one is Aortix by Procerian, as we can see here. It's also a percutaneously delivered device for acute use. And more recently, second heart assist device that can be used for acute use and also for the chronic use. Thank you very much for your attention.
Dr. Krager, that was a wonderful presentation. Thank you so much for this topic, very interesting topic. And this is a new classification and also the way to deal with it. It was a great presentation as usual. Thank you very much. Now, the next speaker will be Dr. Jagi George, who is a specialist in heart failure, an interventional cardiologist at Texas Heart Institute, Baylor St. Luke Hospital. He is going to talk about percutaneous assist device for advanced heart failure and cardiogenic shock. Dr. George.
Good evening, everybody. My name is Joji K. George. I am a cardiologist at Texas Heart Institute, specializing in interventional cardiology and advanced heart failure transplantation. I would like to thank Dr. Halak, Dr. Krager, and the other members of the programming committee for inviting me to speak. We're going to be discussing mechanical circulatory support devices and the interventional treatment of cardiogenic shock and the state of the technology in 2021. Broadly speaking, we have 4 mechanical support devices that we use frequently, starting with the least invasive, which is the intra-aortic balloon pump, the Impella family of products, the tandem heart device when it's used particularly in the left atrial to aortic configuration, as well as veno-arterial ECMO, which is used in biventricular support. So as this schematic shows, as the degree of invasiveness increases, usually so does support. The devices that can offer full left ventricular support in a percutaneous standpoint now include the Abiomed Impella 5-liter pump, or the 5.5 liter, which is the newest iteration of that pump, the tandem heart percutaneous ventricular assist device support, as well as veno-arterial ECMO. Veno-arterial ECMO can also offer biventricular support, which can be needed in some cases. In patients who have severe cardiopulmonary failure, veno-arterial ECMO can also be used for combined cardiac and pulmonary support. This is another schematic that looks at the various devices and the invasiveness of those devices and how these devices work as far as the mechanics. This schematic from the New England Journal of Medicine shows the increased adoption of these devices in the last 2 decades. So the utilization of these devices have increased 16-fold in the graph that we are seeing here, mostly driven by the utilization of the Impella family of devices, which has made the effectuation of mechanical circulatory support much more doable and easier in the cath lab. We'll start with intra-aortic balloon pump. Many of us, or all of us, are familiar with this device from clinical training and has been around for more than 5 decades now. And what this device does is that it offers passive support and afterload reduction. It does reduce myocardial oxygen consumption, and it does so primarily by augmenting of the coronary perfusion by increasing the effective diastolic pressure. It augments forward flow in so doing, but at the end of the day, this is a passive support device that is relatively dependent on some sort of normal cardiac activity. So in a heart that's really not working very well, the intra-aortic balloon pump unfortunately has diminishing returns. The tandem heart device is one of the first percutaneous devices that came to market. This is based on percutaneous ECMO technology, and what this device does is that it offers direct or as direct as possible left ventricular unloading by putting a large bore cannula in the left atrium using a transeptal puncture, as you can see on the schematic toward the right, and using a paracorporeal pump, it's able to deliver this blood into the distal aorta or the iliacs, and in so doing it bypasses the left ventricle, and with this paracorporeal pump can provide full support for the left ventricle in patients in cardiogenic shock. Due to the need for transeptal puncture, 2 large bore cannulations and so on, this can take time to be effectuated and may require practitioners who have more advanced cath lab experience with due to need for transeptal access. The newer devices, namely made by the Abiomed corporations, requires arterial cannulation and is able to effectuate support by crossing the left ventricle with a pigtail catheter and sits across the aortic valve. So these devices for left ventricular support comes in 3 different iterations: the Impella 2.5, the Impella CP, and the Impella 5 and 5.5. Of these, the 2.5 and CP can be done in the cath lab. These devices are either 12 French or 14 French access, usually done through the femoral artery, done using standard percutaneous techniques and sheaths, relatively easy implantation, and used extensively either in shock or for protected PCI in patients who need hemodynamic support during high-risk PCI. The benefit of this compared to the tandem heart is that these devices are in series with the native circulation rather than in parallel, and unlike the tandem heart, and so it does not compete with the native flow and does not necessarily create areas of stasis in the aorta. So these are the various devices that can be used, and one of the benefits of this is that when it's done from the axillary or subclavian approach, as can be done for the surgical pumps or even the percutaneous pumps, the patients are able to ambulate if needed with this in place. Veno-arterial ECMO is something that's of course been used since the dawn of cardiopulmonary surgery, and the indications are broad. It's occasionally used as a bridge to VAD or transplant, also used for cardiopulmonary shock, especially certainly in fulminant myocarditis, in some respiratory illnesses, especially during the COVID era. We've been using this more for patients who are needing not just oxygenation, but also hemodynamic support. Veno-arterial ECMO requires, again, 2 large bore axes, one to the artery, one to the vein, and the pump itself is paracorporeal, and it provides, like we said, full biventricular support and oxygenation. The benefit of this is that it can be rapidly instituted at the bedside. It does not require fluoroscopic visualization, although it helps. And it can be done in patients who are resting pretty rapidly by trained operators. The veno-venous configuration, although it does not offer any mechanical circulatory support, can be used in patients who have pure respiratory compromise in trying to oxygenate. So it's essentially intravenous oxygen delivery to the right side of the heart in patients whose heart and right ventricle is working, but who need oxygenation. Again, this being the era of COVID, this is especially relevant. We've had to do this for multiple patients and respiratory illnesses to either bridge them to recovery or bridge them to lung transplantation. These are the cannulas that we use for veno-arterial ECMO implantation. The red ones are the arterial and the blue ones are the venous, which are longer, which allows us to deliver the cannula into the right atrium for better drainage of the heart. When done in the percutaneous setup, we usually use a right femoral cannulation, but we use an antegrade access sheath into the superficial femoral artery to help perfuse the ipsilateral limb to avoid ischemia in the ipsilateral limb. This shows us the relative flows that can be achieved depending on the arterial cannula sizes. Percutaneous right ventricular support is relatively new. There's two devices that we have that allows us to do this. One is the Tandem Heart Protect Duo cannulation system, where the Tandem Heart paracorporeal pump is used with a specialized cannula that is placed into the pulmonary artery and helps us support the right ventricle, and if need be, can be used also with oxygenation. The other device is an intracorporeal pump, which is called the Impella RP, made by the Abiomed Corporation, which allows to do the same thing, but does not allow oxygenation if need be, because the pump itself is inside the body like the other Abiomed devices. The ongoing challenges is similar to the challenges that we face with long-term mechanical circulatory support. We see thrombotic issues, especially cerebrovascular events. Due to the dependence on large bore cannulas, access site hemorrhage continues to be a challenge. Limb ischemia, like we've discussed, is a challenge. And support, especially when we are using femoral cannulation sites, still requires immobilization. And the large caliber cannulas needed limit smaller patients or peripheral arterial disease patients who are able to get these technologies. The future directions, we are hoping that as devices evolve, they have better biocompatibility to decrease hemolysis and thrombotic issues. Smaller caliber devices would help us make this effective for more and wider population. And expandable sheath delivery systems will help us use it in more challenging anatomy. And we are also hopeful that there is evolution of durable percutaneous mechanical circulatory support devices, which not only helps patients in the acute setting, but can also be bridged for outpatient support at some point. That concludes our discussion. If there's any discussion amongst the panelists, we'd welcome that. Once again, I thank Dr. Halak, Dr. Frazier, and the programming committee for this invitation. Have a good evening.
Excellent, Jaggi. Thank you very much for this review on the mechanical support devices for heart failure. We will hear a little bit more a little bit later, and there will be also questions and answers and discussion related to this topic. So the next speaker is a well-renowned cardiothoracic surgeon from Texas Heart Institute and Baylor St. Luke's Medical Center, Dr. William Kahn. He is a truly well-known expert in the field of VADS and also total artificial heart. The topic of his presentation today is past, present, and future of total artificial heart. And he certainly has a lot of information and updates related to this topic that's really dear to him. Billy?
Good morning. I'm Dr. Billy Cohen. I'm going to be talking about the past, present, and future of the total artificial heart. But before I do, I should point out on my title slide here, you can see I'm a full-time employee of Johnson & Johnson. Johnson & Johnson has graciously allowed me to stay on as a professor at Baylor College of Medicine and to maintain my clinical activity, including research. I'm going to talk quite a bit about Bivacor in this talk, one of the newer total artificial hearts. My interest in Bivacor should not be taken as any indication of interest by Johnson & Johnson, either financial, emotional, or otherwise, in Bivacor. It's purely my own passion. I think everybody watching today knows heart failure is a big deal. In the United States alone, 400,000 people die every year. They spend a lot of money doing it. We can save patients destined to die from heart failure with transplant, but there are only about 3,000 available hearts to service those 400,000 people destined to die from heart failure. So we need an artificial heart. That's not a new concept. People have been working on it as far back at the 50s and 60s. Michael DeBakey had the first successful total artificial heart, working with an Argentinian, Domingo Loyola. He had done a handful of cow experiments showing moderate success. He actually went out of town to Washington, D.C. to get additional funding for the project. And while he was out of town, his then partner and protege, Denton Cooley, implanted it in a gravely ill patient, Haskell Karp, a 46-year-old with end-stage heart failure. The device kept Haskell alive for 46 hours, but because of the valves in the device, it started to hemolyze. Haskell Karp went into renal failure. They did an emergency transplant, and he tragically died 32 hours later. This created a real rift between the two surgical titans, Michael DeBakey and Denton Cooley, and actually sort of delayed artificial heart development, I think. Still, that device that they planted in 1969 is still with us today. The original is in the Smithsonian Institute on display, but the legacy of it lives on in other devices. The Jarvik 7 device, implanted in 5 patients in 1981 and 82, and then that turned into a company called Symbion, which after some difficulties turned into another company called CardioWest, which lasted about 10 years. And now the current company, Syncardia, is producing the legacy of that original device. With each new company, the technology's gotten better and better. The manufacturing techniques have gotten better and better. The durability, the usability, and now in all the different generations, there have been about 1,600 patients implanted. What once was a huge rolling console that the patient had to be attached to with air hoses is now a lunchbox size box, here shown in gray. Now this is a brilliant device and has saved a lot of patients, but it's still a temporary device. Why? Well, that box has to pump air 80 times a minute, and the mechanism that does that wears out. The box has to be replaced every 2 months. That's okay, but you still have air hoses through the body, and perhaps most challenging, the heart that's in your chest is actuating 80 times a minute. That's 42 million times a year. It wears out, and it wears out unpredictably. As a result, the average time someone has one of the devices in their chest is 60 days. It's just a temporary device to keep you alive until they can find a suitable donor. There have been some patients that have gone 4 and 5 years before their devices failed, but by and large, it's a short-term device. You have to have percutaneous hoses, and the internal components can fail. Still, it's the only approved artificial heart in the world right now. Back in the late 90s, Abiomed, a company in Danvers, Massachusetts, tried to make a heart that didn't have the external components that solved some of the challenges that Syncardia faced, and they came up with this brilliant device. It was electrohydraulic. It used silicone oil shuttling back and forth, but still a lot of flexible diaphragms, a lot of valves. One of the main movers and shakers of this project was my mentor, friend, and partner, Bud Frazier. And Dr. Frazier implanted about 150 animals with this device at the Texas Heart Cardiovascular Research Lab before participating in the human implants. And 14 patients were implanted in 2001 and 2002. Dr. Frazier did 5 of them. And of these 14 patients, only 4 of them lived longer than 9 months. The longest one lived 15 months, and most of these patients died when their device broke. The patients that died before that died of infection, multi-system organ failure. It was a real challenge. The device was big. It could only fit in the largest patients. It consumed a lot of power. It was challenging to maintain the balance between the two circulations, the pulmonary and systemic. They flow slightly differently, and if you're off every heartbeat, at the end of a day, you're way off. But its biggest problem was the durability. It beat 100 times a minute. That's 52 million heartbeats a year. No mechanical device can do that. And so the longest device went 15 months before it failed. And so even though the FDA gave them permission to do 60 more implants, AbioCor made a business decision, and in 2004 stopped working on the project, even though they'd already spent $250 million. Now there's another artificial heart that's sort of similar to the AbioCor in some ways, that's coming out of Europe, led by heart surgeon Alain Carpentier, a brilliant surgeon and innovator. This device is sort of similar to the AbioCor, the one I just showed, because it's very big, it's very complex. There's a lot of moving, flexing membranes and valves, but perhaps more brilliant than the AbioCor, and maybe it will succeed where they failed. They've done 20 implants in Kazakhstan, some patients out to over a year, and they just got the nod to release it commercially in Europe, and the nod to start the clinical trial in the United States. The first implant went in 3 weeks ago at Duke in a 36-year-old who's apparently doing very well. So we wish this project well, but it is still a very big device. It's got a lot of moving parts. It consumes a lot of power. So what's the future of the artificial heart? Maybe it's Carmat, but maybe it's Bivacor. Bivacor is a project that Bud Frazier and I are intimately involved in with Daniel Timms, the inventor of the technology, and it leverages the jump from pulsatile valve devices to rapidly spinning continuous flow devices. The pump on the left there, these are LVADs, but that's the HeartMate 1 or the XVE, and you can see how much smaller the HeartMate 2, the first continuous flow rapidly spinning VAD was. It's smaller, it consumes less power, it's much more durable, and Bud Frazier came up with the idea of leveraging that technology to make a total artificial heart. And we started with a VAD that was here in Houston, the Micromed DeBakey VAD, and did a bunch of experiments where we'd replace the heart of a calf with 2 of those, and it had some very successful experiments in the first 50 or 60 attempts. And as a result of that promise, we made a device out of 2 HeartMate 2s, and after doing several animals, actually implanted it in a patient. And although tragically the patient died of liver failure at day 49, the device maintained his circulation very well. And that got us on the radar of Daniel Timms, this young engineer who was developing a device in Brisbane, Australia. Most of the people he showed it to thought it had no merit. He came and showed us, and we immediately wanted to be part of Daniel's team. The device he developed had a single moving part, leveraging rotary pump mechanistics. It was a double-sided rotor. The tall tines on the right took venous blood and pumped it to the lungs. The low pinwheel on the left took the bright red blood returning from the lungs and pumped it to the body. That one moving part was suspended by an electromagnetic field not touching anything, so there's no mechanical wear like modern day VADs, and it could micro-adjust its position to balance the flow between the pulmonary and systemic circuits. He brought together a brilliant team. We got them all to come down to Houston. We were successful in raising some money and have been developing this device now for the last 11 years with them. A lot of people say, well, you need a pulse with an artificial heart, although that's not clearly the case. It may be the case. We can make a great pulse by rotating the single impeller fast and slow and alternating. In fact, you can make any waveform you want. Here's an animal implanted with the device, and I think you'll agree that arterial waveform looks like a normal animal with normal physiology. That's an animal actually with the Bivacor device in place, runs cyclically. Here's a summary of some of the functionality. We can make a pulse, and notice just above there, it can flow 23 liters a minute if we want to. It's much more energy efficient. It can balance the pulmonary and systemic circulation. There's no mechanical wear. We really are very bullish on this device. Here's the actual device. You can see how much smaller it is than every device I've shown you so far. It's about half as big as a can of Coke, and we've implanted this device in multiple animals. Here's an animal out 3 months from implantation, walking on a motorized treadmill, and his cardiac output went from 11 to 14.5 liters with exertion without anybody touching any controls. We've now done design for manufacturing. The device is approaching clinical readiness. Here's one of the clinical pumps. We've got a good interaction with the FDA and know what our preclinical milestones or hurdles are, and we anticipate first in man will be in the not too distant future. Again, as you can see from this slide, we've done 28 animals up to 90 days. So I'd like to summarize by saying I think continuous flow pumps, just like they showed that they were the solution for LVADs, left ventricular assist devices, I think they're well suited for integration into the next generation of total artificial heart. If you need a pulse, you can make one quite easily with these devices. The decreased size, marked mechanical complexity, improved power efficiency, and dramatic improvements in durability of these type of pumps should be beneficial. And I'll go out on a limb here and say that the first practical permanent mechanical replacement for the failing human heart will be continuous flow. Thanks a lot.
All right. Well, I think that was amazing. Thank you so much, Dr. Coach, for that wonderful lecture. I believe that Dr. Emerson Perrin is going to go next. He has some emergent things to get taken care of. So he wants to present to us about stem cell therapy, the latest advances in stem cell therapy for congestive heart failure. And I want to tell you about Emerson Perrin. He and I go way back. Wonderful man, so intelligent and passionate about stem cell therapy. So take it away, Dr. Perrin.
Hi, my name is Emerson Perrin. I'm the medical director of the Texas Heart Institute, and it's my pleasure to present here at the 4TS meeting some perspective regarding cell therapy in the treatment of congestive heart failure. I'll start briefly by addressing the aspect that this is the Gartner hype cycle, and it shows how new technologies and things that are novel go through a certain defined cycle in which things are initially thought to be extremely incredible and are going to solve all the problems and are just amazing. But it takes a while to get data and to understand these things until you really have a productive output of some of these new technologies. And I think this applies perfectly to what we've seen in cell therapy. And you may even be thinking, well, yeah, cell therapy, this is something that really hasn't worked. Well, it's because it's a complicated kind of treatment, and it takes years of understanding and applying and successive and serial trials to understand how it works. So I'm going to take you very briefly through this because of our limited time. And again, addressing the aspects of heart failure, which you all know. Not only ischemic heart failure was depicted in this slide, but also this may be applicable to patients with non-ischemic heart failure as well. Here you see multiple mechanisms of action of cells, which were initially thought to be sort of magical in being able to regenerate tissue. What we really know is that that's not how they work at all, that it's really a paracrine mechanism, one of immune modulation, both at the microvasculature in the heart and also in the vasculature in the body, and that these cells work locally and at a distance depending on the different cells. And really, they offer a completely a distinct pathway of treatment to heart failure than we're normally used to. Heart failure treatments in general are addressing the neurohumoral aspects of heart failure, decreasing volume overload, and And here we're really talking more if we're going to be able to use cells to modify the natural history of heart failure in addressing the underlying inflammation, which we know exists in heart failure. So this is a series of trials. You can see on the left the different cell types that we've evolved through over the years and multiple multi-center and different randomized trials, and learning the first lessons all the way through to a phase 3 trial, which I'll talk about at the end. Our delivery of cells has been directly into the myocardium using three-dimensional mapping system. And the very first trial we did, which was a first in man, using autologous bone marrow cells in these severe chronic ischemic heart failure patients. And this was in collaboration with the Procardiac Institution in Rio. And I'm Brazilian, and we worked there. We had a system at the time and did the first cell therapy trial of heart failure in Brazil. Here you can see a very dramatic picture, especially on the top, which represents voltage, which is essentially viability and an electrical awakening of the heart with cell therapy. So in the beginning, we were very excited. You can see here VO2 max increase significantly in the treatment patients where it remained kind of flat. But again, this is a single center, initial, small number of patients. So that initial sort of exciting experience that generates, at least in my own case, really some belief that there was a future in this therapy that warranted our pursuing this. Given that it's a biological therapy, it is rather complex, and we've then had to go through many lessons and learnings as we do this. Here's one of them for you as an example. That same curve that you see here in the next study that we performed in Houston called Focus HF, the same data showed superimposed curves. We had to go back and take a look at the data. What we found is when you plate these specific cells that we used from this therapy, these cells and stem cells, that's a property as they grow colonies. And you can see the number of colonies that they're growing. Only 2 patients went into the normal number of colonies. All of the other treated patients, you can see that grew very low number of colonies. And so this gives us a red flag in terms of autologous therapy. We went back and thought about what might be the things that might be influencing this. And age is very obvious because stem cells work much better when you're 18 than when you're 80. And so we divided the population in the mean of the age. We looked at the different age group, and then on the right you can see the separation in functional capacity according to treatment and control. So this is the kind of lesson that we have learned and applied over multiple trials. Here's the subsequent trial in 90 patients. So, going from the first trial of 17 to a trial of 30 to a trial of 90. And again, this is all with the same product. So these are autologous bone marrow mononuclear cells. And as we've learned, this is a relatively weak cell product. But you have to go through this to learn these lessons. And so as we think about the problem with autologous cells, if different people have different comorbidities and the potency of their stem cells is very different, then it's like you're giving, even though you're giving the same medicine, you're giving a different dose to everybody. And that just is not something that works very well. So we think about what are different solutions that we can address. One of them is conditioning of the cells, or actually the marriage of gene therapy to cell therapy, which I think will have an incredible future, something that we're working on very diligently. And so you can modify the cells that you're giving in many different ways. Or you can select a different bone marrow cell altogether. Or you can go out of the bone marrow into different tissues. And finally, I'm just going to talk about this last item, which is using an allogenic cell source, which is very interesting because now you can take that very young person, harvest cells, and have those very potent cells be the same therapy in all the patients throughout the trial. Now, this has to be a cell that's immune tolerated, so that's an important aspect of that. And so here's an example. The mesenchymal cells are sort of fly under the radar of the immune system, and this is actually a cartoon of MPCs, and these are precursors to mesenchymal cells, and they're not plastic adherence derived as normal mesenchymal cells are, but they are immunoselected. So it's like if you pick 1 in a million of the cells in the bone marrow and you grow those cells. And so that'll give you an off-the-shelf kind of drug profile for a cell product. And in the cartoon you can see that pointing to the mechanism of action of these cells, which are, you can see in the blue there, the MPC, have receptors for example, inflammatory cytokines, and so you can see IL-1 beta, TNF alpha can influence these cells, plug into them. The cells realize that they're in an environment of inflammation, and so they put out things to counteract that inflammation. One of the more important aspects of this, and as we learn now the mechanisms by which we're addressing heart failure, is polarizing M1 to M2 macrophages. This is very important in my view, not only at the level of the heart, but at the level of the general circulation, as well as other effects. And so we now have a much better understanding of how these cells work. And I show this slide just to make the point that these same cells, when they're applied in an LVAD trial, showed a 70% reduction in GI bleeding. So cells injected in the heart at the time of an LVAD implantation giving you a significant reduction in GI bleeding, which we know is a complication of continuous flow pumps. So that demonstrates that point very well, that you have a local effect and you also have a systemic effect. And so I want to briefly review this phase 2 trial in which we use these specific cells in patients with both ischemic and non-ischemic heart failure at 6 centers. This included 60 patients. I'll show you the design of the trial in just a second. Intramyocardial injection, and very importantly, we looked at the safety of this product, because this is the first time that we're injecting allogenic cells into the heart. So this is something that the FDA wanted to look at very carefully. You can see there in this dose escalation study from 25, 75, 150 million, you can see under there the different dates where we underwent regulatory review. In each of the groups there are 15 treated patients and 5 controlled, and we follow these patients for 3 years. This is a busy slide, but just to mention the average ejection fraction of these patients is around 30%. And first of all, I won't go into the details, but essentially these cells are very safe. They do fly under the radar of the immune system. There are no issues related to injecting the allogenic product in the heart. And then let's look at some of the anatomic highlights of this trial. And so if you look in the middle panel, because that was the endpoint at 6 months, but you see 3 months, 6 months, and 12 months. In the middle panel, the light blue, you can see the control, and we're looking at end-systolic volume, and then you can see the 3 doses, 25, 75, and 150 million cells. You can see a dose-related reduction in the end-systolic volume and actually going to a negative or decrease in volume with negative remodeling, utilizing these cells at the endpoint of 6 months, which is maintained at 12 months. And we've seen this in cell therapy before. What's more difficult to see is an effect on end-diastolic volume. And here you see a very similar thing, a significant change with reverse remodeling, decreasing the volume of these hearts at the 150 million dose in a dose escalating fashion. If you think about proportional changes in systolic and end-diastolic volumes, we would expect to not see a change in ejection fraction, and that's what we didn't see. And we also looked at functional parameters such as 6-minute walk. You can see at 12 months there's what I would say was a biologically significant increase of 50 meters in the 6-minute walk, which did not reach significance, but helped us understand that there was a functional correlate to what we were seeing. And probably most importantly, as you all know the natural history of heart failure, how these patients can go into the hospital and ultimately some of them have a lethal exit with episodes of decompensation. we looked at cardiac MACE and heart failure MACE in these patients, based essentially heart failure, rehospitalization, cardiac death. And you can see that the 150 million dose, there were no events, whereas the 25 and the 75 million dose tracked together with the control. So what's interesting there is this is very much like a bone marrow transplant where you have a threshold effect and you have to give a certain number of cells to reach an effect, and we see the same thing in the heart. And then this is very encouraging, although it's incredible, over a 3-year period of time to have no events in the 150 million group. And what we needed to do really is then use this trial that I've just described as a basis for a phase 3 trial, more definitive trial. And that's exactly what we did. So the DREAM-HF study, which I just submitted the late-breaking clinical trial abstract to American Heart Association for November. Monday, the deadline was at 6 p.m. And we are in the process of publishing this study. We may do it simultaneous, and maybe we can publish this beforehand. But I just want to share with you some of the excitement that we have about this study, which really goes to then try to answer, is there effectiveness, clinical effectiveness in a cell product such as this, using the mechanisms that I've showed you, addressing the inflammatory aspects of heart failure. And so in this trial, we used the 150 million dose, which was significantly the best dose in the phase 2 trial. This is a study that was conducted in 570 patients across 52 sites in the US and Canada, in which we used a patient enrichment criteria for those with heart failure to try to tease out those with more events, and actually some post-adaptive design, which are interesting, but not something that we want to talk about right now. And again, the MACE was reviewed by independent clinical endpoints committee. DSMB reviewed the study. We passed a futility analysis about halfway through the trial. And so I think that we're with this trial and pointing to the different aspects that I have shown you, I think we'll be able to reach a new point where we are now in cell therapy in terms of a new therapy. And as we have worked on this for the past 20 years, we now have entered a period in which we start having relevant data that will hopefully make a important clinical impact. And so I think that approval of cell therapy as a distinct and novel way to treat heart failure is something that we now can see on the horizon. So thank you very much for listening to me. It was a pleasure to present to you today.
Dr. Perrin, what a stimulating lecture that was. I want to thank you so much from the bottom of our hearts. And we want you to stick around for some of this question and answer. We're going to do an early Q&A session, 5 minutes for this. And I'd like the speakers to kind of be ready. Dr. Perrin, there you are. You are the first one going to get my question there. You know, the idea of immunology as being the forefront, the core really, of our cardiology education experience. Would you comment on that? And in our cardiology fellowship, since you trained me, would you find that to be so part of the program, to be such an important part of that program? And number two, in diastolic dysfunction or diastolic heart failure, do you think stem cell therapy will be a mainstay in the future?
Well, thank you, Annie. Good to see you. So to answer the first part of your question, if you think about it, and studies over the last many years have really pointed to the fact that the process of atherosclerosis is basically driven by the immune system. It is an immune-mediated process. And if we can modulate that process, we can modulate the progression of atherosclerosis and decrease events in patients. So that's a very, very important pathway. And this whole idea that inflammation is a very important component in many patients with heart failure is now understood. And so by modulating that inflammation, again, we're maybe able to change the course that some of these patients have that as an important component. As far as HFpEF, HFpEF is a complicated thing, and there was just a paper released in European Heart Journal looking at the molecular mechanisms of HFpEF, and it was multiple pages with all these hot maps, and I'm not even sure I understood about 20% of it. But I think there will be a lot of development in that. I think there are other target molecules and many things that will be able to affect that in the future, but we're still a ways from being able to affect that from a mechanistic standpoint. So we're not there yet. And actually, one thing that we're doing at the Heart Institute now that we're working very diligently at is developing a fast and a very robust model of HFpEF in large animals. And so, you saw Billy Cohn, demonstrating all the work that goes on down there, and we'll be working very hard in a HFpEF model in the near future that can be reproduced and that we want to share with other places around the world.
Thank you for sharing your wealth of knowledge with us. Dr. Krazier, do you have some questions to ask us?
I have a question for Dr. Rogers and also for Emerson. Emerson, thank you for sharing this latest information, which is absolutely exciting when you told me how inflammation played a significant role in heart failure. And as I have mentioned in cardiorenal syndrome, tissue necrotic factor alpha and interleukins play a very significant role in both conditions. So I would like to ask Dr. Rogers, Joe, you mentioned all the clinical trials that have been carried on or are going on as far as heart failure is concerned. Did we miss that point that we maybe should be using combined therapy and concentrating on the inflammation in addition to other medications and drugs that we have been using in the past?
Zvonko, I think it's really an interesting question that you raise. And, we had actually done some work using anti-inflammatories, particularly anti-TNF alpha drugs, and those trials were negative. The way we understand heart failure, it isn't a pro-inflammatory condition. And it seems like it should be an obvious target for some of our pharmacotherapy. I'm just not convinced that today we are confident about the targets and that we're not confident about the drugs that we should be using to target those pathways. So I think that in the end, it will be an important part of our treatment approach, but I don't think that we're quite there yet.
Thank you. Emerson, any additional comments related to this?
Well, one of the beauties of cell therapy, number one, it's that it's very complicated, but as opposed to giving one molecule or one medicine, you're putting a cell in that has a capability of recognizing the environment it's in. If that happens to be inflammatory, then to secrete multiple cytokines and proteins that then may affect that inflammation that has other effects, like I'd mentioned. Polarizing M1 to M2 is very, I think it's a very important mechanism, but also having direct effects on the microvasculature, on the cardiomyocytes, and actually the vasculature at a distance. So these cells, if they're like little factories, and they're smart factories. So if you can put them in the heart and they recognize things and are able to then really give you a more broad type of response than you can get by giving a single drug. So that it's definitely a different approach, and hopefully it will hold the answer to some of these things.
What about a combination of angiogenesis and what you're doing now? Do you think that that aspect also is important in treatment of heart failure?
Well, it may be important in terms of preserving and saving maybe some of the microvasculature and some of the effects that inflammation has on apoptosis locally in the myocardium. We know that cell therapy, one of the low-hanging fruit of cell therapy is being able to
to perform angiogenesis. It's the other things that are difficult, but I'm sure that is one component of what the cells may bring to this treatment.
Dr. Roger, if I can ask about SGLT, this is a new for cardiologists to use for heart failure patient, and you mentioned to start early. Do you have to up titrate the dosage? What do you look for when you give the medicine? And when do you say, well, it's not doing much, probably we're going to skip that medicine and give some more, the others, all the standard ones, because you know the patient getting a lot of pills now, the heart patient. So we want to be sure whatever pills we're going to give is really doing what we're looking for.
Yeah, no, I think that this is really an insightful question, and I think it's one of the real challenges that we have in heart failure pharmacotherapy, because we've used a sort of building block approach to our treatments, where we keep adding more and more drugs that ultimately will either be hemodynamically or financially intolerable for patients. And we've never really gone back and deconstructed that complicated and increasingly complicated drug regimen to try to rationalize it. I really like that approach that Packer and McMurray proposed in the European Heart Journal a couple of months ago, where you start with drugs that seem to have the greatest potential impact on outcomes. And the way we're understanding that today, it actually could be that it's the SGLT2 inhibitors and the beta blockers, then adding on an ARNI, and then subsequently adding on an MRA. And then using some of the subtleties of other pharmacotherapy after you get that foundational regimen put together. The SGLT2 story, I think, is absolutely fascinating. And I'm not convinced that even today we have a clear understanding of how those drugs have a favorable impact on heart failure outcomes, but it's very consistent across all of the trials that, as you know, started in diabetics. And now we're enrolling non-diabetics in trials, in the SGLT2 trials, who just a patient population that has heart failure. A quick follow-up, in my talk, I mentioned that the Emperor preserved results would be released yesterday. And again, once again, in a heart failure population of individuals with an ejection fraction of over 40%, randomized to empagliflozin or placebo, there was a 21% reduction in the primary endpoint of mortality and heart failure hospitalization. So I think it's a powerful and potent drug to add to the heart failure regimen.
Thank you.
Omar, can I make a quick comment on this?
Please go ahead, Firas.
Of course, if Joe is involved in the discussion, it's always wonderful, first of all, to see him, and importantly, to kind of ask him and benefit from his expertise. Congratulations on your new transition to Texas Heart Institute. I want to highlight that Dr. Rogers had contributed to the education of heart failure here in the region. He's been at the ACC Middle East, both in Saudi Arabia and in UAE before. So we look forward to seeing him again soon in the region physically. But I wanted to just comment on this issue of heart failure classes by just saying that perhaps the best way to decide on the sequence of heart failure medications is what I like to call setup-based approach to heart failure management, because all these recommendations and suggestions on how to sequence heart failure therapies are based on the fact that there are plenty of heart failure clinics that are going to see patients relatively frequently and put patients on heart failure classes of medications within a short period of time. What I worry about, especially as you go farther and farther from North America, is the fact that the prevalence of heart failure clinics or clinics that are dedicated to see heart failure patients, for that matter, even if we're not calling them heart failure clinics, might not be as widely available. And in that sense, we have to kind of revisit this and sometimes decide on which would be the most important in treating the patient, with understanding that they may or may not be seen within a short period of time. I can tell you that from my experience in the region here, it's very unusual to see patients within 2 weeks after discharge from the hospital post-heart failure admission, for example. Sometimes this means changing the approach and using things even before patients leave the hospital. And when they come to clinic, it may not mean that they're going to be seeing in these clinics very regularly because, of the lack of heart failure dedicated nurses or physicians. So again, the setup, I think, makes a huge difference when it comes to how you use heart failure medications and how to up-titrate them.
Yes, we have to proceed with the next speaker. I think there was a minor change in the program. I think Dr. Miller will be next. Dr. Craig, want to present Dr. Miller?
Yes, it will be my pleasure. So Les Miller is well-renowned specialist in treatment of heart failure. He participated in many clinical trials together with Dr. Rogers, and he has tremendous experience in that field. He is a current Chief Medical Officer of Second Heart Assist Device. And the topic of his presentation today is the update on treatment of Class 3 congestive heart failure and cardiorenal syndrome with Second Heart Assist Device. Les?
Thank you, Mr. Chairman. And I'd like to begin by thanking Dr. Kracher and the organizing committee for including us in this very important symposium on the latest interventional advances in the treatment of heart failure. What I am about to present to you, I believe, represents one of the biggest paradigm changes in the field, in that it represents a change from totally surgical discipline to an interventional catheter-based treatment of advanced heart failure. The Second Heart Assist Device is a temporary percutaneous mechanical assist device placed in the descending aorta. It is the only true aortic stent graft in that it is the only one that occupies the entire aorta, and as such can augment the entire native arterial pulse rather than relying on entrainment of flow going by a pump. This is an impeller-driven pump mounted on a drive shaft placed inside a stent cage. The stent cage is the same as the original Talent stent graft, which was the first stent used for endovascular repair of aortic aneurysm, now used in over 400,000 cases with rare, if any, reports of movement once deployed. It achieves this stability by virtue of a strong radial force that is applied along the entire length of each of the struts placed circumferentially around the aortic wall. And yet, this stability does not come at a price, in that the aorta was able to maintain pulsatility, compressing the stent with each pulsation, which will be important for chronic delivery. This pump is able to generate up to 2.5 liters of flow and is arguably the most efficient pump in the field, in that it achieves these flows at by far the lowest RPM speed required of only 7,500 RPMs, which is in marked contrast from the 25,000 RPMs for Impella and 35,000 RPMs for the Procerian and 35,000 for the Impella device. This is a look at the entire system. Once the catheter exits the body, the drive shaft contains a handle which controls independently the deployment and retrieval of the stent cage and the impeller blades. It has the only motor outside the body, and this system is connected to an alarm box and a control box which adjusts RPM speed. This is a close-up of that handle, and as you can see individually, there are wheels that, when turned clockwise, allows for the full deployment of the stent, and separately the impeller blades. And conversely, when turned at the end of the case in a counterclockwise direction, it closes the impeller blades and the stent for complete removal. This is an ideal visualization of deployment of the device. When the wheel is turned, the sheath is removed and the stent opens completely to its 22 millimeter size. Then the impeller blades are opened under fluoroscopic guidance. The speed is adjusted for the duration of the case. At the end, the impeller blades are again collapsed along the axis of the drive shaft and the sheath advanced over the stent. Then the entire system removed to the end of the 14 French sheath used for vascular access, and the entire sheath and catheter removed in toto. In our first 4 patients, this complete deployment of the device, both sheath and both stent and impeller blades, required less than 2 minutes after arterial access. This is a look at the device in situ. It is very much resembles an intra-aortic balloon pump with roughly the tip at the level of the diaphragm, but in so placement, the inferior margin of the stent is only 10 centimeters or less above the orifice of the renal artery, as you can see, providing this excellent renal support. Our first in-man application of this device was for high-risk PCI support in Asuncion, Paraguay. Dr. Adrian Ebner has a practice of high-volume coronary intervention and generally does cathing 14 or so patients the beginning of each week to decide what patients will require intervention. We identified 4 of these 14 patients whose anatomy was defined as high risk by current criteria. These patients had a full contrast study the day before our study and came to the lab with documented evidence of prerenal azotemia, had low cardiac filling pressures, and importantly showed very low urine output in the 1 hour prior to then receiving yet a second large contrast load for dilation of at least 2 sites of high-risk anatomy. And yet, despite that, the patients all exhibit a very significant improvement in urine output, averaging 400% over the baseline the hour before support. No patients had any problem with hemodynamic support, and renal function was unchanged at the time of hospital discharge. We believe this is strong support also for the renal protective effects of this technology in patients with chronic kidney disease who require contrast angiography. But as the topic of today is high risk or is advanced heart failure, we believe that the ideal target population for our device is those 15 to 20% who develop true diuretic resistance and have worsening renal function despite 24 hours of IV diuretics, so-called cardiorenal syndrome, clearly is associated with increase in mortality and complications. As such, it's been the target of at least 12 drug trials in the past 5 years, all of which have failed to meet their primary endpoint as they're targeting a single mechanism in a very complex dynamic interaction between the heart and the kidney. And as such represents one of the biggest unmet needs in the entire field of heart failure, potentially up to 125,000 patients who would require now a mechanical solution. We are ready now to begin our first in man of cardiorenal syndrome early feasibility study in the United States for 10 patients using 24 hours of initial support that will take place at the Cleveland Clinic and Ohio State University, actually starting next month, with primary endpoints of improving renal function and urine output. But we believe that the even larger segment of the advanced heart failure population is the ambulatory class 3 population. This has never been accessed by the large durable valves because of their underlying complexity, intervention, and importantly, complications. We believe that of the nearly 1 million class 3 heart failure patients, as many as 300,000 are potential patients for this application by virtue of impaired renal function, difficult diuretic management, and recurrent hospitalizations. But to get into this class of support, it will clearly require wireless power and will require a catheter-based approach. This is a diagram of the second generation of the second heart assist device, which, as you can see clearly, continues the use of the stent cage and the impeller blades mounted on a drive shaft, being able to utilize all of the preclinical animal research, mock loop testing, and computational fluid dynamics to design the contour and length of our blades. We did not have to start with an entirely new model. Using that frame, we only increased the tip to allow a larger battery for receipt of the wireless power. One of the other very unique and novel advances in the field has been to use a magnetized ball mechanism on the tip of the drive shaft that will allow it to be very tightly adheres to the stent to allow deployment, as has been shown in these videos. But importantly, for the chronic application, the ball can be demagnetized and the drive shaft removed entirely, leaving the stent in place in situ with no external wires or attachments. This is a look now at the deployment of the second generation device, and you'll see very similar mechanism of having it be able to have the sheath withdrawn and the impeller blades opened up, and yet now the demagnetized ball allows the drive shaft to be removed and the impeller blades begun and spun at as low as 2,500 RPMs for support in these chronic heart failure patients. If there's recovery or a need to retrieve the device, the magnetized ball simply re-grabs the stent and the device pulled back to the level of the sheath used for insertion and the entire system removed. This very, very low RPM speed required comes at a use of less than 2 watts of power draw, which will markedly enhance the durability and minimize heat generation. And the low speed really minimizes any risk of hemolysis in the long-term application. This is a look at the wearable vest to house the external power source for this wireless power. As you can see, it's a very lightweight, breathable vest that is very easily designed for both men and women with adjustable Velcro straps. The power source is inserted inside a waterproof pouch that allows this system to be totally waterproof, including the controller that you can see at the bottom of the vest. The battery source supplies up to 36 hours of continuous support, and with a hot swap to a second battery provides 72 hours of continuous support. This system draws less energy than is required for operation of your cell phone and has Bluetooth-enabled control of the device. This truly represents one of the biggest advances in the field of mechanical support to not only be wireless, but to allow patients for the first time to either wear this right into a shower as they're both the vest and the controller are waterproof, or disconnect entirely, be completely untethered for the first time in the history of mechanical support. Finally, this is a look at the device in situ. Imagine this being placed less than 10 centimeters above the renal artery, providing an additional 2.5 liters of flow and 50% increase in renal blood flow for long-term support of heart failure and hopefully preventing progression of the disease. In summary, we believe that the second heart assist device is the easiest of all the devices in the field to insert, requiring less than 2 minutes for total delivery. It does not require precise location, and importantly, will unlikely to ever need to be repositioned for movement. It operates at by far the lowest speed of any device in the field, which will be associated with the lowest hemolysis, and provide up to 2.5 liters of additional flow over native pulsatile flow that provides up to a 50% increase in renal blood flow support of advanced heart failure. It is the one device designed for both acute and chronic heart failure, and we're happy to report that our clinical trials for cardiorenal syndrome will begin, in fact, next month at Ohio State in the Cleveland Clinic. Thank you. Thank you, Mr. Chairman. And
we thank you so much, Les Miller, for that wonderful talk. It was so informative and very interesting, exciting for the future of heart failure therapy in the interventional world. Now we're going to bring Dr. Samarsheth, and he's from Texas Heart Institute, interventional cardiologist, working with Dr. Krazier on the, and he's going to talk about the ALIVE trial, update on the ALIVE trial, the hybrid approach, a surgery and endovascular approach for reduced LV ejection fraction and congestive heart failure. And Dr. Krazier has been very excited about this trial. He would like to emphasize that ischemic cardiomyopathy patients with akinesis and or dyskinesia and SCAR are amenable to treatment within this trial, and they're eligible with or without aneurysm. So everyone pay attention to this next lecture. It's going to be fabulous.
Hey guys, I'm Sam Sheth. I'm one of the cardiologists here at Texas Heart Institute, and I'm going to take a couple of minutes to talk to you about the American Less Invasive Ventricular Enhancement Ischemic Heart Failure trial that we have ongoing here. So as this is CME, I have no disclosures. And some of the objectives of today's talk, we're going to define the magnitude of the problem. We're going to understand the unmet needs, a brief overview of the current interventional options for heart failure, and then a review of the ALIVE trial, which will be the bulk of this 5-minute talk. So in general, heart failure, as you guys know, is very epidemic, you would say, or pandemic. There's about 7 million patients in the US with heart failure. It takes a majority of our healthcare dollars go to care for these patients. And interestingly enough, 70% of these are ischemic. And a lot of these ischemic patients are due to late presentations of MIs or just the natural history of heart failure after an MI. In fact, 20% of patients after an ischemic event develop heart failure later in their life, which often needs further care or leads to an enlarged ventricle, or which then in turn also leads to mortality. So the problem is akinetic or disconnect myocardium is associated with low output, heart failure, ventricular arrhythmias, or even thromboemboli due to localized thrombus formation. And so we think, or we feel with this trial, that the root problem is the scar. So while coronary deaths have decreased by 50% due to early intervention, heart failure incidence has nearly tripled. For ischemic heart failure patients with LV remodeling, live therapy can help provide a minimally invasive option for reverse remodeling. And so this is a little schematic of all the players involved. There's interventional cardiologists, there's cardiac surgery, electrophysiologists, echocardiographers and MRI specialists, heart failure doctors, as well as general cardiologists. And all of these people work together to come up with the next best step for heart failure interventions. As you can see here on the left of the screen, in class 1 patients, usually meds are all we really need to do to help prevent further downward decline. However, as time progresses and heart failure advances, they start to enter into higher Intermax levels, higher New York Heart Association classes, and then can possibly need a VAD or transplant. Right now, very few things are available between the class 2 to class 3 options, and that's where we hope Live can fit in. So what can we do right now for interventional heart failure options? Well, there's a lot of things we can do by catheter basis now. We can do Watchman devices, we can do mitral and tricuspid clips, we can do valves either in the mitral position or even in the aortic position, commonly the TAVRs. There's clinical trials looking at septostomies. And now this device in particular, from Bioventrix, the Alive device, can be used to help remodel the ventricle as well too. So how does this work? It's really a simple solution. You look at wall tension or Laplace's law, and we want to reduce that wall tension, reduce the amount of area there. So to take that out, you basically exclude the scar. Very similar to a door procedure that Dr. Cooley first did. This is a little animation of the mechanism of action for this device. So as you can see, there's a large bore axis in the IJ, usually 14 French. We place an internal anchor right in the RV septum. And then from the outside, the surgeon via mini thoracotomy places an external anchor, and then literally we cinch it together to exclude the aneurysm or the dead tissue or the part of the LV that is not viable. Then what we do is we visualize on TE to make sure the tricuspid valve is okay, the mitral valve is okay, make sure the right ventricular free wall is still moving okay, because we do exclude the septum, which is a big part of RV contraction. And if that all looks okay, we can disengage and leave the anchors in place. You kind of remodel the heart, and this is a closer view of a pre and post angiogram to show what the ventricle looks like after the clips are in place, or the anchors are in place. So why does this work? Well, in all the clinical trials, especially the SITCH trial, you can see that reduction of end systolic volume index can improve mortality or improve cardiovascular function. So to the left is how much volume reduction we get with this device, the Bioventrix Alive device, versus the standard of care therapies we have right now, which is the CRT-D, Entresto, MitraClips, Carvedilol. Interestingly enough, Farxiga is not yet on this, but I suspect it'll have a similar effect between Entresto and MitraClip as well too. This is another schematic of a patient that we've done. On the left, you can see that the ventricular volume was markedly increased, 127 milliliters squared, and then post-procedure, after the anchors, we reduced it by 46%. This is a little outline of what the new ventricle looks like, and just to show you how much we change it, we can move it to the other side, and you can see how much of the akinetic or dyskinetic tissue we've excluded and why this works. What does this show? Well, overall, there's been LVF improvement in quite a few number of patients. That's to the left of the screen, and then to the right of the screen, you can see what improvement we get with clinical numbers that are often very important in heart failure trials. Quality of life improves, heart failure class improves, and the 6-minute walk test improves as well too. This slide here is the safety data set representing whether or not this procedure itself is safe. This is majority from the data done in Europe where this is already approved. Of 72 patients, there was only 1 mortality due to anaphylaxis, and there's only been about 3 patients with some sort of adverse event. The biggest complaint or issue that people often have with this is, are we going to affect the right ventricle? And it turns out in this data set in particular, only 1 patient had any trivascular valve issues. bleeding or pulling the anchors through the ventricle has not been reported. So what's the trial design? And this is the US trial or the American trial. There's 120 patients that we're enrolling. 80 are going to be in the treatment arm and 40 in the control arm. We're currently at 2/3 enrollment, and we're trying to improve heart failure symptoms, the quality of life, and prevent readmissions. We also want to confirm that this is actually a safe procedure. So what are the key inclusions? You have to have LV scar, which is discrete akinetic and or dyskinetic segments. LV scar location, currently this is for basically anterior MIs, so anterior wall, and we like to have the septum involved too, because I mentioned the RV is where one of the anchors sits. We need an EF less than 45, a large ventricle, and we want patients to be in optical therapy before we proceed. Exclusions, if there's thrombus in the LA or LV, we don't proceed. If the PA pressures are very elevated due to the concern for possible RV failure, we don't do this. And if they had a prior surgery, they're excluded as well too. MR is a relative exclusion because you could argue that by reshaping the ventricle, the annular plane may shrink and improve MR, although right now it is considered a key exclusion. Those patients may be CLIP candidates or other mitral valve candidates. So overall, we want to show that this therapy can improve the LV function, reduce LV volume, and reduce our HF symptoms. And we hope and we think that the root cause of LV dysfunction after an ischemic event, or an anterior MI in this case, is due to scar progression, and that by basically excluding the scar, we're going to improve function. So in summary, heart failures, particularly ischemic, affects a large population of patients. Pharmacotherapy is a mainstay, but now various interventional procedures and devices have helped to improve quality of life and life expectancy. And there's still a population of patients that have an unmet need and have limited benefit from current treatment modalities. And that's where we think this device in particular and this trial fits in very well. So patients with a history of LAD MI, now with SCAR, may be a great candidate for this trial. For more information, you could email me directly or email our research team. And then I'd like to thank Dr. Krazier and the 4TS committee, Mr. Duncan, who's part of the Bioventrics committee, the THI group, my partners, my family, and then most importantly, the patients for letting us work with them and their families. Hey guys.
Thank you, Dr. Shisfor. This is a wonderful presentation, and this is a new technology, and looking forward to see the result of it. Look like very promising technology for treating heart failure with aneurysm. Next talk will be the Novartis Symposium. Dr. Firas Badr, he is a clinical professor of medicine and vice chairman of Department of Cardiovascular Medicine at Cleveland Clinic, Abu Dhabi. He's going to talk about essential management of heart failure. Dr. Firas.
Thank you very much, Dr. Amr and the 4TS committee for this excellent program and the kind invitation to participate in the panel. My job tonight is kind of to summarize some of what has been mentioned already earlier in the presentation, especially in Dr. Rogers' presentation on medical therapy for heart failure, but to highlight some of the issues related to what we know today and where we're heading next. So we all know that sympathetic nervous stimulation causes a lot of the harm we see in heart failure patients. And this actually happens not just through the stimulation of the sympathetic nerve receptors, but also through the activation of the renin-angiotensin-aldosterone system, resulting in effects like myocyte hypertrophy, ischemia, dilatation, arrhythmias, vasoconstriction, and sodium retention, basically contributing to the symptoms that we see in heart failure patients all the time, and that contribute to their hospitalizations and eventually to their mortality because of disease progression. We've learned that beta blockers work to reduce mortality and morbidity in heart failure patients, but we've learned that we have to do this in specific doses and through getting patients to target doses that we acquired through clinical trials. So metoprolol worked in a specific dose, and the target was 200 milligrams per day. bisoprolol at 10 milligrams per day. We learned from the MOCA trial that we have to try to get carvedilol, for example, to 25 milligrams twice daily, because this did result in decreased mortality and cardiovascular hospitalizations, as well as improvement in left ventricular ejection fraction in a statistically significant manner. Angiotensin II is the end product of the renin-angiotensin-aldosterone system activation, and that is responsible for a lot of the harm we see in the cardiovascular system, starting with endothelial dysfunction all the way to contributing to end-stage cardiovascular disease, including heart failure. We've learned from the Paradigm Heart Failure study that the effect of sacubitril valsartan is very clear on reducing all modalities of death when compared to enalapril in patients who are relatively optimized otherwise for heart failure therapy. This included all causes of death, cardiovascular causes, sudden cardiac death, as well as worsening heart failure. In fact, when hospitalization benefit was seen, it was seen as early as the first 30 days of the randomization. Mineralocorticoid receptor antagonists represent an important class in heart failure management as well. And despite the belief that was common for a while that blood pressure kind of limits the use of these medications, we learned that this, regardless of the blood pressure, these medications actually help patients with the reduction of cardiovascular death or hospitalizations for heart failure, regardless of their starting blood pressure, simply because improving hemodynamics ultimately leads to improved blood pressure rather than reduced blood pressure. And then came the SGLT2 inhibitor class, which is a very exciting class, like we heard earlier in the evening. SGLT2 inhibitors are now viewed as comprehensive cardiometabolic class of medications that contribute to glycemic control and weight loss, but also natriuresis. But beyond that, what we think of SGLT2 inhibitors at this point is that they're not just glucose lowering, but comprehensive cardiometabolic renal modulators. They seem to reduce inflammation, oxidative stress, fibrosis, intraglomerular hypertension, and sympathetic nervous system activation, but they may also improve mitochondrial function and myocardial efficiency. In this nice meta-analysis from Dr. Zanad, piling the data from DAPA, HF, and Emperor reduced heart failure trials with reduced ejection fraction, we clearly concluded that first hospitalization for heart failure or cardiovascular death will be significantly reduced when we add SGLT2 inhibitors to the regimen of heart failure patients with reduced ejection fraction. The update from the American College of Cardiology to the 2017 expert consensus talked about these classes of medications, but actually placed RAS blockade and beta blockers as the starting entry point to the management of these patients. And then depending on their overall profile and comorbid conditions, other things could be added. But I want to stress that the key thing is getting patients on classes of medications that are proven to help heart failure patients as soon as possible and in the most efficient way, keeping in mind that certain medications need to be titrated to target doses while others do not need that titration. So the sequence will vary from one clinic to another and one setup to another and one patient to another. So individualization, I think, is key, including things like cost and compliance between different patients. To complete the spectrum, we had to tackle heart failure with preserved ejection fraction. This is the Paragon heart failure trial, which looked at the comparison of sacubitril valsartan with an active comparator, in this case, valsartan in heart failure patients with an ejection fraction of more than 45%. And in this study, the primary endpoint of heart failure, hospitalization, and cardiovascular death barely missed the statistical significance. And the number that keeps getting quoted in different meetings is the 7 events that could have made the difference between this being statistically significant or not. Again, this was against valsartan and not placebo, and taking patients with an EF of more than 45%. Fresh from the press is Emperor Preserved, which is empagliflozin and heart failure with preserved ejection fraction. The two differences here that are worth mentioning is that this was empagliflozin versus placebo and was in heart failure patients with an EF of more than 40%. So kind of included a little bit more LV dysfunction patients because, as I will show you, this LV dysfunction is a continuum and it's not really a specific cutoff point between reduced and preserved. Having said that, the primary outcome of cardiovascular death or hospitalization for heart failure was significantly reduced by empagliflozin versus placebo. So again, giving us more good news about SGLT2 inhibitors in the management of this group of patients and kind of giving us hope in heart failure with preserved ejection fraction, a category that was very difficult to manage over the past 3 decades, and where many of the studies have failed to prove benefit for different classes. I will not dwell too much into this, but Dr. Rogers mentioned also that mineralocorticoid antagonism is potentially helpful in heart failure with preserved ejection fraction. This is the TopCat study, and based on the analyses that showed that most patients benefited. If we take out Russia and Georgia participants, then it seems that this is a very reasonable class of medications to consider in these patients as well. Now, the reason I'm showing the CHARM program here is not to review the original CHARM program, but to show you what I mean by this continuum of ejection fraction. The CHARM program included CHARM added, which is adding candesartan to ACE inhibitor treated patients with LV systolic dysfunction, CHARM alternative in patients who did not tolerate ACE inhibitors, and of course CHARM preserved in patients with preserved ejection fractions regarding of whether or not they were treated with ACE inhibitors. And what I wanted to show you from this more recent analysis is that the benefit continued to be seen all the way until pretty much what we consider a normal ejection fraction. So this benefit of neurohormonal blockade does not stop by the exact cutoff that was used in clinical trials to determine reduce from preserved ejection fraction. But in fact, it is somewhat of a continuum. And if we look at the primary endpoint of hospitalization for heart failure or cardiovascular death, at the top left corner here in heart failure with reduced ejection fraction, the CHARM program collectively actually showed significant benefit until throughout the ejection fraction range until it became normal. Same thing with heart failure and mid-range ejection fraction, and it wasn't so in HFpEF though. This is another interesting analysis that utilized the CHARM program one more time, because the paradigm compared sacubitril valsartan to enalapril. The CHARM alternative, of course, used candesartan in patients who did not tolerate ACE inhibitors. So there was so from that we could conclude a theoretical comparison between sacubitril valsartan and placebo in patients with reduced ejection fraction, and similarly in HFpEF, because the Paragon was a comparison with valsartan, and CHARM preserved was using candesartan in patients with HFpEF. A theoretical analysis here was sacubitril valsartan versus placebo. And all I would like to show you here is that if you use this kind of statistical approach, you will see significant benefit for cardiovascular death or heart failure hospitalization in all different categories and different endpoints, specifically based on this theoretical analysis versus the placebo versus sacubitril valsartan. So just to highlight where we are now, sacubitril valsartan was actually studied extensively in patients with heart failure and reduced ejection fraction, was evaluated in different groups of patients, was evaluated in regards to the progression of renal function, natriuretic peptides. Remodeling was studied with sacubitril valsartan, and important conclusions were made from the prove and evaluate trials. Quality of life was improved with sacubitril valsartan. And if we look at different classes of heart failure medications, and that's where these are very, very important classes to use in order to save lives of heart failure patients, it is indeed important to remember that things like basic neurohormonal therapy, as well as ICD and CRT therapy, and now SGLT2 inhibitors are all important to improve morbidity and mortality, and with very low number needed to treat in order to save one life. So in summary, we now have better understanding of the spectrum of heart failure. We're less concerned about the ejection fraction per se, but more about a continuum of a disease process driven by neurohormones and manifesting through a series of remodeling features. Today, the best evidence, I believe, for the full spectrum of abnormal EF is from RAS blockade, specifically with sacubitril valsartan, but we continue to get more data from different classes, and it will be very exciting to see how heart failure therapy changes over the next 5 years. Thank you.
Thank you, Dr. Bader. It's interesting information that you provided to us. The next presentation is by Dr. Gabriel Lohr. He's a cardiothoracic surgeon at St. Luke's Hospital, Texas Heart Institute, CHI Medical Center in Houston, Texas. He is an expert in the field of organ transplant with heart and lung transplant, but also a cardiothoracic surgeon. His topic today is the current status and the latest advances related to heart transplant. So, Gabriel, it's a pleasure to have you here.
Thank you very much, Dr. Kritcher. Can you see my slides okay?
Yes, we can see it clear.
Perfect, thank you. So it's a real privilege to be here. Thank you for allowing me to do this one live. We'll give you an update on heart transplantation. In terms of disclosures, I have only to disclose that our institution received some grant support for trials related to left ventricular assist devices, but I personally do not receive any financial incentives from them. End-stage heart disease has been covered here in this conference as it has been likened to a pandemic, and that is very accurate because 26 million people are estimated worldwide to be struggling from end-stage heart disease. This is a patient with burned out non-ischemic cardiomyopathy caused by severe mitral valve disease, has had over 3 different operations for her mitral valve. And at the age of 35, actually, I did her heart transplant, a 4th time reduced sternotomy heart transplant, and she's done very well. So what we're here to discuss today is for these patients who have very end stage refractory irreversible heart failure after exhausting medical management and less invasive procedures, is what options do we have available to us? Because their mortality is very high. It's on the order of about 50 to 70% for some, for patients in New York Heart Association class 4 out to 1 year. So this is a real major problem. Thankfully, we live in an era right now that is actually very optimistic. We have very advanced mechanical support devices like the left ventricular assist devices. And we have heart transplantation. And both of these entities, while they do still have their challenges, are at a very mature state right now. If you compare this to, for example, lung transplant or liver transplantation, we really don't have mechanical support options in those patients. So the field of heart transplantation as an entity for patients with heart failure is very exciting right now. When we look at plots such as this, it tells us that devices are getting better. If you look at the lowest curve here is the cohort from the rematch trial, which everyone knows, a very sick patient cohort that was offered optimal medical management instead of LVAD. As we go up from there and we look at the newer and newer generation LVADs, the survival out to 2 years is actually getting closer and closer to heart transplantation. So it's very important, because otherwise the waitlist mortality would be very high. It would probably be about 30–40%. But thanks to the ability for us to offer patients other therapies, we're able to keep that waitlist mortality down closer to 10–15%, which is still pretty high, but not as bad as it would be otherwise. This slide just highlights that heart transplant is still the better therapy, all things being equal. If you have a heart transplant, you have a survival advantage over a patient who just remains on left ventricular assist support, so-called destination therapy. This curve over here denotes a bridge to transplant patients who had an LVAD, and then a transplant, or patients who just had a heart transplant. In all cases, heart transplantation confers a survival benefit. And the reason for that is just because the mechanical support, even though it is excellent right now, there's still room for improvement in some of the morbidities, particularly stroke, infection, needs for exchange and bleeding complications. They are low, but it is enough of a competing risk over time that it doesn't quite allow us to just forget about heart transplant just yet. These are the major indications for heart transplant. The majority are non-ischemic, followed by 32% of all cases being ischemic cardiomyopathy. So these are the most common killers worldwide, and the most important, but there's a lot of other important etiologies as well. About 50% of cases now are bridged with mechanical support. In general, the evaluation starts with history and imaging that confirms irreversible and refractory heart failure. And then we go into our planning where we repeat our echoes, left heart cath to look at the anatomy, right heart cath to ensure there's not irreversible pulmonary hypertension. Cardiopulmonary stress testing is very helpful, especially in difficult to decide situations. If the peak VO2 is below 10 to 14, that's a very good indicator for us that this patient, in fact, does have irreversible and refractory heart failure. And then we do a variety of imaging, lab evaluations to plan the operation, a variety of consultants to help mitigate the risks of the procedure. An ideal candidate would have irreversible refractory heart failure, would have a BMI less than 30, age less than 70, PVR less than 4 Woods unit, would have limited peripheral vascular disease, or at least something that's correctable, no renal disease, limited comorbidities, good social support, no smoking history, etc. Having said this, obviously we're presented with many challenging scenarios every day. We have a multidisciplinary board that meets every morning, every Tuesday morning, once a week, to review these cases, and ad hoc as needed. Because a lot of times we have to look at patients who are less than ideal and try to figure out ways to improve their lives and offer them a second chance at life while mitigating the risk to them and to the ability of other patients to get transplanted as well. And I think we do a very good job of that at the Texas Heart and Baylor. Now, these are the patients who get listed most commonly. Status 1 are patients who are crash and burn in the hospital, in cardiogenic shock on VA ECMO. They have the highest priority. Status 2 are patients who are also very sick, cannot leave the hospital. They're on some form of mechanical assistance, but more stable than our status 1s. Status 3 is still also prioritized pretty significantly, but these patients would have an LVAD probably at home, or they may be on inotropes and some degree of cardiogenic shock, plus or minus being discharged. As we go down to status 4, 5, and 6, these are a little bit harder to get transplants for, but we have a lot of exciting options, which I'm not going to highlight right now, related to ex vivo heart perfusion that's going to allow us to have more donor organs for these patients in status 4, status 5, and status 6. And we are very anxious to get started and enrolled with several of those trials. This is the donor heart, excellent quality, being evaluated at the donor hospital by our procurement team. This is the recipient operation once we have the go. We are cannulated ascending aorta, SVC, and IVC. We've opened the right atrium. We've looked at the fossa ovalis, and now we're coming across the dome of the left atrium. In order to complete that, we're opening up the root of the aorta, and that's going to give us a better view of the dome of the left atrium. Here you can stare into the right ventricular outflow tract. And now the left atrium is completely exposed. The aorta and the pulmonary artery have been divided. We identify the coronary sinus, and that gives us a real nice landmark to continue our dissection along the groove, posterior to the posterior mitral valve annulus. And that gives us our best resection. What we're trying to do in this case, we remove the heart from the field, but we need to ensure that we have an excellent landing zone, that we've prepared the recipient appropriately to now accept the donor, the new donor heart, which may sometimes be bigger, may sometimes be a little smaller. So we have to take all of these things into account and prepare the recipient vessels accordingly to ensure that we have a beautiful aorta, pulmonary artery, IVC and SVC to sew to. And so that's what we're doing here. We're making sure we have plenty of room. We're removing any excess tissue that we don't need. Now we start sewing the left atrium. We start at the level of left atrial appendage, and this is the left superior pulmonary vein. We have to be very sure that we are very clear and away from the pulmonary veins as we sew this to make sure we do not occlude anything. We're coming across the back wall of the left atrium here, sewing this very methodically. It's a very long proline suture. Once we're done with the left atrium, in this particular case, we go straight to the aorta, but there are other ways to do it, and more commonly, we go straight to the IVC. But in this case, by going to the aorta, it gives us an advantage because we're able to remove the cross clamp a little earlier. So for patients who came from farther away, from donors that come from California or New York, this may be a very nice strategy because so far we've only taken up about 20 minutes of ischemic time, and then we can remove the cross clamp and start perfusing the heart quicker. So this is, again, a proline suture going along the back wall of the aorta. We're very meticulous in this area to ensure that we don't have any bleeding complications, very difficult to take care of them in this particular area. We really try to minimize our rates of take back for bleed, and thankfully they're actually quite low. Here now the clamp has been removed. You can see that there's blood ejecting through the RVOT. This is the pulmonary artery that we're sewing now. The heart is already beating, but it's decompressed. Here we still have our IVC and SVC cannulas in place. We've completed the pulmonary artery anastomosis. You can see the cross clamp has already been removed from the heart. Now we have 2 more anastomoses to complete here, and this is the inferior vena cava. And we're sewing along the back wall, and we're taking great care to make sure it's properly oriented. And here's the SVC anastomosis. Again, very important to make sure that it is not stenosed, not too long, not too short. So we take great care to do that properly. Now, results for heart transplant survival have been improving by era. As you can see, at 5 years, the survival is excellent, 75%. It's almost double the survival advantage that we see with lung transplant now. So heart transplant survival has been improving significantly, particularly as we go into our most current eras. Very importantly, a 1-year survival is what we're judged by and what is a very important landmark for all programs. 85% is what is expected at Baylor, St. Luke's, and Texas Heart. We have over 90% 1-year survival. If a patient survives 1 year, conditional on 1 year survival, their 12-year outcomes are even better, and they're expected to live out 80%, 75%, even out to 12 years. We have survivors who are 20, 30 years out of transplant right now. We have a very unique organization at Baylor St. Luke's Medical Center Heart Transplant Program with CHI Baylor, St. Luke's, Baylor College of Medicine, and the Texas Heart Institute. Multiple firsts in the field, first heart transplant, first LVADs. We've performed over 1,500 heart transplantations here, over 1,600 LVADs. We have an unparalleled surgical staff. Dr. Frazier is the real pioneer of the entire program. Dr. Kenneth Liao runs the Division of Cardiothoracic Transplantation. Heart transplant director, Dr. Shafi. I'm the surgical director of the lung transplant program and co-director of the section of adult cardiac surgery, and share in the call pool on heart failure, heart transplants, and LVADs. And we have an exceptional cardiology staff led by Andrew Civitello to ensure that that we meet those metrics for our first year survivals are excellent. So with that, I want to thank you to the entire staff for allowing us to present our data here today.
Well, thank you so much, Dr. Lohr, for this is a wonderful presentation and a wonderful video you show us with the surgery. I mean, it looked very simple to us, but I'm sure so delicate. And you done the heart transplant in 3 minutes, so it was very impressive the way you can handle the transplant. Thank you so much for this wonderful presentation.
Thank you, Dr. Halle.
Thank you, appreciate it. Thanks. Next talk we'll have Dr. Omar Latouf. He's a professor of cardiovascular surgery at Mount Sinai Hospital, New York, USA. He's going to talk about convergent procedure for atrial fibrillation heart failure patient. Dr. Omar.
Good day. It's my pleasure to be with you today and present my work on the convergent procedure, a team's approach to catheter ablation for persistent and long-standing persistent atrial fibrillation. Atrial fibrillation is a problem that causes increased risk of stroke, increased risk of heart failure, and increased risk of dementia and mortality by the loss of atrial contraction, the development of atrial clots, and the worsening cardiac function. Furthermore, 10-year follow-up on patients with atrial fibrillation as compared to patients who are in sinus rhythm, there is significant decrement in the survival of such patients, causing us to address this issue. The incidence and prevalence of atrial fibrillation has increased worldwide as documented by this data produced a couple of years ago. The hemodynamics of atrial fibrillation are worthy of briefly mentioning. As such, it causes fall in cardiac output, leading to hypertension when it's acute, decreased exercise capacity when it's chronic, pulmonary congestion, and ultimately heart failure. The work of Hesuguri has led to us learning substantial information on the causes of atrial fibrillation and the location of arrhythmic foci in the pulmonary veins and in the atrium, as well as superior and inferior vena cava, and has led to a substantial understanding and work. Here is a graph that shows trigger sites for atrial fibrillation. Important to note this as it clearly outlines the posterior wall of the left atrium, as well as the pulmonary veins and left atrial appendage, which will be the target of our work and further discussion. Credit goes to Will Seeley at Duke University in the 1970s and 80s, and my friend, Dr. James Cox, whose name has become synonymous with the Cox-Maze procedure and has practically taught the world on the management of atrial fibrillation. Dr. Cox started with the cut and sew ablative procedure in the 1980s and 90s, but quickly that migrated through the work of our cardiology colleagues to the use of energy sources such as microwave, which did not work, ultrasound, which did not work, laser, which did not work, and ultimately radiofrequency, which has been successful, and cryoablation has been successful. The Cox-Maze procedure originally required cutting and isolating basically the posterior wall of the left atrium and isolating the pulmonary veins from the rest of the heart, then sewing it back, excluding the left atrial appendage. This is quite a difficult procedure to do and has been associated with high frequency of bleeding, and thus we have migrated to the use of energy sources successfully. Radiofrequency ablation in surgical procedure is done as shown in this figure, and effectively now we can do pretty much the same procedure, minimally invasive. Cryoablation also works in isolating the posterior wall of the pulmonary, posterior wall of the left atrium and the pulmonary veins. Catheter-directed ablation of the irritable signs in the posterior wall of the left atrium when it's done totally endocardiac, has been fraught with concerns for atrioesophageal fistula due to ultimate perforation of the posterior wall of the left atrium and fistula formation with the esophagus. Luckily, this is not uncommon. Luckily, it is uncommon. However, when it does happen, it is disastrous. We published an article on 3 such patients where we managed them surgically. The CONVERGE trial is the most exciting trial in the world of atrial fibrillation that was run out of my institution, Emory University, with participation from 37 institutions around the world. An FDA-approved trial. It's the first prospective multi-center randomized controlled trial to compare and evaluate the safety in persistent and long-standing persistent atrial fibrillation. It is minimally invasive that utilizes combined epicardial subxiphoid access and endocardial access. The lesion sets are described here in the hybrid approach. The surgeon makes entry through the subxiphoid space and ablates the posterior wall of the left atrium. Then the cardiologist will go transfemoral, transvenous, and will ablate the pulmonary veins from inside and performs the connection lesion toward the isthmus of the mitral valve. While the endocardiac catheter procedure, there is no surgical subxiphoid approach. It's all endocardiac isolation of the pulmonary veins and a superior lesion and the posterior wall of the left atrium and a connecting lesion. The surgical approach requires a small incision in the subxiphoid space where entry is made and a port is introduced, requires electronics to be brought into the operating room and end up with a small 1-inch incision. Here is an image of the ablation of the posterior wall of the left atrium. The Episense catheter is introduced with video visualization of the posterior wall of the left atrium. Suction catheter is applied to the posterior wall of the left atrium. Water is used or saline to irrigate the area to keep from superheating, and the posterior wall of the left atrium is ablated. This is what the posterior wall would look after posterior wall of the left atrium would look like, gray, discolored, and electrically silent. The results of this data, which has been accepted by the FDA, and since then, on April 29, 2021, the FDA approved the Episense as a device for treatment of atrial fibrillation, giving recognition to the hybrid procedure of combined surgical, minimally invasive, and endocatheter. At 30 days of the trial, there has been no deaths, no cardiac perforations, and no atrioesophageal fistula. There has been an 18% difference between the convergent arm and the control arm in patients at 12 months. The atrial fibrillation burden has been reduced by greater than 90%, which means that patients who had been in persistent or long-standing persistent atrial fibrillation most of the day, their burden has been reduced to less than a few minutes a day. The data has confirmed to overall greater than 23% advantage for the convergent arm over the control arm. Figuratively, here is the primary effective of the hybrid convergent. At 1 year, nearly 68% of patients are free of atrial fibrillation as in the convergent procedure as compared to 50% in the endocardiac catheter ablation alone. So in summary, endocardiac ablation for persistent or long-standing persistent atrial fibrillation has limitations. Least invasive hybrid approach offers better long-term results. At 30 days, no deaths, no cardiac perforations, and no atrioesophageal fistula in the trial. There's 18% difference between the convergent arm and the control arm at 12 months, and there is over 90% a atrial fibrillation burden reduction. Thank you very much for attending this presentation. I look forward to hear from you and answer any questions.
Dr. Latu, thank you for an excellent presentation there. So interesting. We're going to move forward with Dr. Zachary Ian Winnett, cardiac electrophysiology from the Imperial College of London. Such a pleasure to have you here talking about conduction system pacing for heart failure. Dr. Winnett, go ahead.
Hello. It's my pleasure to join you today to discuss conduction system pacing for heart failure. My name's Zachary Winnett. I'm a consultant cardiac electrophysiologist and work at the National Heart and Lung Institute at Imperial College London, and I also work at the London Heart Practice and the Harley Street Clinic. These are my potential conflicts of interest. There are two broad indications for implanting a pacemaker. There's pacing therapy for heart failure, which is going to be my focus today. But of course, many pacemakers are implanted for bradycardia pacing, and it's been increasingly recognized that the way we deliver ventricular pacing can potentially impact heart function in the long term. And it's been increasingly recognized that right ventricular pacing and the desynchronous activation that results in, certainly in a proportion of patients, can lead to impaired heart function. And therefore, conduction system pacing may well have an important role for preserving normal physiological activation and preventing the development of heart failure in patients who require bradycardia pacing. The focus of my talk today is pacing therapy for heart failure. And so what we're trying to achieve with pacing therapy for heart failure is to identify symptomatic patients with impaired cardiac function and impaired electrical activation, which impacts the cardiac function, and to treat that with pacing therapy. And the aim is to correct the impaired electrical activation and result in improved cardiac function, and therefore longer-term improvements in function for the patient. Now, biventricular pacing, of course, is well established as an important treatment for patients with heart failure and broad QRS, or principally left bundle branch block. It's been shown in large, high-quality randomized controlled trials to improve both symptoms and reduce mortality. So why might we consider alternatives to biventricular pacing? In some patients, it's not possible to implant a left ventricular lead via the coronary sinus due to anatomical limitations. And it'd be nice to have an alternative approach for delivering cardiac resynchronization therapy that can be performed at the index procedure. In addition to this, there is some evidence that suggests that it may be possible to deliver improved ventricular resynchronization, and that biventricular pacing there is missed potential in terms of the amount of ventricular resynchronization that can be delivered. We see only modest reductions in total ventricular activation time with biventricular pacing, and it does not return the activation time back to the level that's seen in patients with a normal narrow QRS. There's been increasing interest in conduction system pacing as an alternative method for delivering CRT. We know that in patients with left bundle branch block, it's often possible to deliver dramatic reductions in QRS duration by positioning a lead on the His bundle itself. And we think this is because in many patients, the block which leads to left bundle branch block occurs in the His bundle itself. And we could, either by pacing distally to this or pacing at the site of block with using increased energy, but we can recruit those fibers that were previously blocked and therefore normalize ventricular activation pattern. There's an increasing body of literature from observational studies to show that permanent His CRT therapy is technically feasible in many patients, and it delivers impressive reductions in QRS duration and improvements in symptoms and echo measurements in observational studies. A further approach for conduction system pacing is to target the conduction system slightly more distally and the left bundle. So with left bundle branch pacing, using a transeptal approach, which was pioneered by Professor Huang in China, the lead is buried deep into the septum, and stimulation results in capture of the left bundle and therefore rapid activation of the left ventricle. We get nice narrow QRS durations with left bundle branch pacing, and we can often correct left bundle branch block. But we do see a slightly delayed right ventricular activation, and that's evidenced by the R wave in lead V1. There's data from observational studies in patients who have non-ischemic cardiomyopathy and left bundle branch block, which shows there is a high implant success rate with left bundle branch pacing, and that this results in impressive improvements in QRS duration, as well as improvements in left ventricular ejection fraction and left ventricular volumes, as well as symptoms in this observational study. The data from observational studies supports the concept that conduction system pacing may be a useful way for delivering treatment to patients with left bundle branch block and heart failure. However, it doesn't give us a direct comparison with biventricular pacing. We address this question with an acute within-patient comparison of His bundle pacing versus biventricular pacing in patients with left bundle branch block and heart failure. And we assessed left ventricular activation time using the CardioInsight system, and also performed high precision hemodynamic assessment of the two pacing modalities to directly compare them. And what we found was that biventricular pacing delivered a modest reduction in left ventricular activation time. His resynchronization therapy delivered a significantly greater reduction in left ventricular activation time compared to biventricular pacing. And excitingly, this improved ventricular resynchronization over and above that delivered with biventricular pacing delivered a significantly greater improvement in acute hemodynamic function. Therefore, we have acute data which suggests that his CRT may be even more effective than biventricular pacing for delivering CRT. But of course, what we need is randomized control trial data. Currently, we do not have large-scale randomized controlled trials, but we do have the HIS-SYNC pilot trial, which was a relatively small trial which compared his CRT with biventricular pacing. And while there was a relatively high crossover between treatments in the HIS-SYNC trial, the on-treatment comparison did demonstrate that his CRT delivered significant improvements in echocardiographic response and change in left ventricular ejection fraction. And there's a trend towards a greater improvement compared to biventricular pacing, but this was not significant. A subsequent similar sized study found similar findings with improvements in symptoms and echo measurements with his CRT. Again, this study wasn't powered to detect superiority over biventricular pacing. His CRT has recently been adopted into the ESC guidelines as an alternative method for delivering CRT in the case of unsuccessful left ventricular lead implantation. I focused on this talk principally on patients with a standard indication for CRT, namely patients with a broad QRS and left bundle branch block. However, there is potential that conduction system pacing could be used to target alternative electrical targets. We have data from observational study which shows that his CRT appears to be useful in improving outcomes in patients with right bundle branch block. And we've been investigating whether delivering His CRT in order to optimize AB delay in patients with a long PR interval improves outcomes in the HOPE-HF trial, which we'll be reporting the findings of soon. Therefore, to conclude, conduction system pacing is a promising alternative to biventricular pacing in patients with left bundle branch block and can be used in lieu of a left ventricular lead. This is based on data from observational studies and small randomized controlled trials. Conduction system pacing appears to have the potential to deliver improved ventricular resynchronization compared to biventricular pacing and deliver acute improvements in hemodynamics. We do, however, need adequately powered randomized controlled trials to compare His CRT versus biventricular pacing to determine whether these acute improvements in cardiac function translate into longer term improvements in outcomes. There may also be the potential to target alternative electrical targets with His conduction system, with conduction system pacing.
Thank you so much, Dr. Winnett, for this wonderful presentation. If we have some discussion, probably keep it toward the end. Next speaker will be Dr. Yahya Kiwan. He is a consultant interventional cardiologist and specialist in stem cell therapy. He's going to talk about stem cell therapy for heart failure. Dr. Yahya.
Hello, everybody. This is Yahya Kiwan. I would like to thank Omar, my close friends and colleague, for giving me this huge opportunity to talk about a very exciting topic, which I believe strongly in it, is stem cell therapy in heart failure. I'm sure Dr. Perrin will present his talk. As you know, he's one of the pioneers in stem cell therapy, but I will try my best to give my part of the presentation. Now, the issue is stem cell therapy and answer to heart failure. What I'm going to do is one of the literature review, which was published by Tahzeeb and his group in December 2019. Sorry, October 2019. Now, the question is, can patient with heart failure experience a return of left ventricular ejection fraction and ventricular geometry to normal? Now, we know that the current medical treatment of heart failure is having an excellent effect on improvement in symptom and survival. And as you know, there is a long list of medications, which we definitely knows that 40% of patients with cardiomyopathy might experience a return of his left ventricular ejection fraction to normal, 40%. But we don't know whether the LV function has recovered or we in remission. So a trial was done to answer this issue called TREAD Heart Failure Trial, presented or published in the Lancet 2019. And to answer the question whether withdrawal of patient medication who has fully recovered his left ventricular ejection fraction, if we withdraw, whether we will get maintained improved ejection fraction and symptom, or there is a recurrence. So this trial has presented two groups of patients, one withdrawn from the medications and one maintained on medications. And it's only just after 8 weeks, 44% of patients whom withdrawn the medication, they have a relapse. And this is reflected by the reduction in ejection fraction, again, increase in cardiac biomarker, and increase in left ventricular volumes. So these results clearly indicated that even after years of productive research on the development of advanced medical therapy, it is not yet possible to reverse the underlying pathological process. So consequently, there is an important need for therapies to durably restore ventricular function, and one approach is focused on stem cells. So this meta-analysis will focus on this issue. I'll start with Patel in 2005, who presented a 20 patient with low ejection fraction, two groups during bypass surgery, one injected with stem cell therapy directly during operation, and the other group were only bypass surgery. And what they found, there is a clear evidence that there were increase in left ventricular ejection fraction in patient with autologous stem cell therapy, and there was no adverse side effect. Other study done by Skashander, 2006, this time was not direct surgery, but intracoronary injection of bone marrow-derived progenitor cells. In this study, it shows significant reduction in cardiovascular mortality, reduction of acute ischemic event, and increase in ejection fraction. Another study, 2010, in this type of study, they used intracoronary injection of stem cell therapy. The name of the trial called STAR Heart study. This time was autologous bone marrow derived stem cell therapy. They have a 5 years follow-up, showed improvement in the NIHA and the ejection fraction and ventricular function, mortality, and reduction of arrhythmias. And in 2012, an interesting study comparing the allogenic versus autologous bone marrow-derived stem cell, again with different injection technique. This is transendocardial needle catheter infusion of stem cell called Posidone trial. And what they found, both allogenic and autologous stem cell have significant effect in reduction in the area of infarct and quality of life. And the interesting thing they found, there is no significant antibody response to autologous to allogenic stem cells. So we could say clearly it explains that the risk of immune rejection or damage with the use of allogenic stem cell is too low to jeopardize their clinical usefulness. Another study, Donadorf 2012, he published an article on update on cardiac stem cell therapy in heart failure and suggested that phase 1 and phase 2 clinical trials on stem cell based therapy are safe and effective, but yet he suggested we need more multicentric phase 3 trial are needed before any further conclusions are drawn. Another study, 2013, using cardiopoiesis, and in this trial called C-CURE trial, the cardiopoietic stem cell therapy in heart failure, and analysis in 2 years showed improvement in cardiovascular functioning status using such cells in ischemic heart failure. So ejection fraction improved, and systolic volume improved, and NIHA function. 2012 chart-1 trial, we have the use of cardiopoietic regenerative therapy at 39 weeks. Interesting thing, in this trial, they compared with a sham procedure. So, it's very interesting study. The result of this trial showed no excess harmful effect were reported in the stem cell group, lower incidence of sudden cardiac death in this group of patients, decrease in end diastolic volume. A very, very interesting trial by our colleagues, Dr. Perrin, who had his presentation earlier than me, because we don't know the exact dose to be used in patient with heart failure. So the dose, the so-called dose threshold, he used 3 types of doses: 25 million, 75 million, or 150 million cells. The MSC used in this trial were processed by immunological selection methods. The cells were delivered to patient by transendocardial injection. And the result from this study that there is significant improvement in MACE, and MACE were observed in 22% of patients who received stem cell compared to 33% of the control group. And the heart failure associated cardiac event were found to be lower in all 3 dose cohort group. Another trial by Premier and his group, 2015, allogenic mesenchymal stem cell restore endothelial function in heart failure by stimulating endothelial progenitor cells. And what they found, it was observed that allogenic stem cell enhanced the endothelial progenitor cell count at 3 months follow-up. This study confidently asserts the advantageous effect of allogenic mesenchymal stem cell on endothelial cells. A review article by Poglajian, 2015, stem cell in non-ischemic cardiomyopathy using CD35 stem cell in non-ischemic causes of heart failure, improved cardiac function and symptoms. Another trial called MSC heart failure trial, which is randomized placebo-controlled trial using bone marrow-derived mesenchymal stem cell conducted in Europe in 2015. And the result of this trial showed improvement in end systolic volume and ejection fraction, stroke volume, myocardial mass, and fewer patients need hospital admission. And the adverse effect of stem cell therapy were found to be negligible in this trial. The conclusion that this review has gathered that many studies favor the benefit of stem cell, showing that it not only improve the primary cardiac condition, but also help to avoid further decline in the functionality of the heart. The advent of this promising modality can benefit many individuals who either are not candidate for surgery or do not benefit from medication. However, the inconsistent results and interperson variability in outcomes of the existing study on stem cell still an area of concern and warrant an extension of the spectrum of clinical studies in this trial. Thank you for listening.
Thank you, Dr. Yahya, for this wonderful presentation on this very exciting subject, and probably going to be very important in near future as a curative for heart failure. Hopefully, we'll have some more update of those trials in the upcoming conferences. The last talk for tonight is Dr. Annie Verghese. She is with us here on the panelist also, and she's going to talk about EECP for the treatment of heart failure. Dr. Annie is a medical director of advanced cardiovascular care in Houston, Texas. Annie?
All right, I'm just setting up the slides there. We're going to share the screen. And what a pleasure and an honor to be here, Dr. Halleck and Dr. Krazier. Let's see, going to start from the beginning.
Delighted to have you.
There we go. All right, great. Thank you. I'm so passionate about an external counterpulsation, and I love to talk about it around the world. So I only have 8 minutes, so here we go. Target population for external counterpulsation is actually coronary artery disease patients with angina, refractory to medical therapy. We know that NCD guidelines in the United States for Medicare cover that, but also congestive heart failure patients can benefit from this. And many of the insurance companies and Medicare do cover for heart failure patients. Patients with disabling angina pectoris who, in the opinion of their cardiologist or cardiac surgeons, are not readily amenable to invasive procedures because they're inoperable or at high risk of operative complications. Their coronary anatomy is not readily accessible to such procedures, or they have other comorbid states. So heart failure definitely comes into play in this. But the most exciting thing that I want to talk about here is ECP in COVID-19 heart failure. So there are several publications, one in the European Journal of Heart Failure in August of 2020, talking about patients with COVID-19 having a significant incidence of acute heart failure associated with very high mortality rates. And those patients with a history of heart failure are prone to developing acute decompensated heart failure after COVID-19 diagnosis. And I had several patients like this who actually became much more ill after their COVID-19 diagnosis. We see that we have ARDS and pulmonary hypertension, right heart failure developing, and this sympathetic activation increase that many of our speakers have talked about increased the RAS, volume overload, stress cardiomyopathy, LV dysfunction, and heart failure. And as Dr. Krazier was talking about the renal impairment causing this volume overload, and the septic shock patients that many of our speakers talked about, even using ECMO because of LV dysfunction in the COVID-19 heart failure patients. So all of our talks have kind of touched on this, and because of this pandemic, we all are so faced with this terrible effect of COVID-19 on heart failure patients and causing heart failure. The inflammatory mediators are very important, as Dr. Perrin talked about, causing this myocardial depression. And we see direct cardiac injury, myocarditis, thrombotic activation, ischemia, and also increased metabolic demand causing ischemia. All of these pathways are leading to heart failure. So we have a whole new set of patients that need our help with regard to heart failure treatment. And the goals of the treatment is to optimize preload and afterload, inotropic support, mechanical circulatory support, all of these things that we've talked about. The heart failure patients show significantly worsening clinical presentation, and they have a higher all-cause mortality. And Ray and Associates discussed that perhaps these patients are less frequently admitted to ICU, less often receiving mechanical ventilation. And that paradox illustrates the difficulties of allocating medical resources during such a pandemic. I have seen my patients waiting for ICU transfer, and some of them have had to have terrible catastrophe in the institution where they were because they could not get to a higher level of care. So a significant number of heart failure patients with advanced age, comorbidities may have limited access to critical care units. So that may be one of the causes of this pandemic within a pandemic, I would say. And even if severe presentations of COVID-19 may require the temporary reduction or withdrawal of ACE and ARB or other medical therapy as a result of hemodynamic or renal deterioration. So a lot of these patients are getting off of their medications. And I actually had a patient who went home from another facility and all of his medications were stopped. So we must restore this, this medical therapy, guideline-driven medical therapy that's been proven to impact the course of heart failure. So in that introduction, I want to talk about, beyond that is the external counterpulsation. How does this work? We want to increase the coronary blood flow in diastole. EC procedure is a series of 3 cups wrapped around the calves, lower thighs, upper thighs, and buttocks, sequentially compressing upon diastole, improving the coronary flow, increasing venous resistance, and systolic unloading, increasing cardiac output up to 25%. Now, many of you may never have heard about external counterpulsation or enhanced external counterpulsation, but the regimen is 35 hours. The benefit is seen 10 to 14 days in treatment. So some of the studies have shown even just 2 weeks of therapy have benefited. I was just telling Dr. Halleck that one of my patients, who's my uncle actually from Oregon, increased his ejection fraction from 15% to 30% after 6 weeks of therapy. So I'm very excited about external counterpulsation. But beyond me, from the 1950s, the Kantorowicz brothers, Sarnoff, Bitwell, Gorlin, all of these great investigators showed improvement in ejection fraction, ischemia, in multiple clinical trials throughout the years. And it kind of fell off favor in the 1970s. People were not able to use this hydraulic external counterpulsation mechanism. It was kind of archaic. But that in the 80s, China and Sarnoff, investigators there redeveloped the technology and created a pneumatic system, which we use today. So there were several clinical trials in 92 in SUNY, the Stony Brook trial, showed in 18 patients with chronic angina refractory to medical therapy, and showed the benefit that all patients reported improvement in anginal symptoms. So after Stony Brook, there were other clinical trials. This is in Stony Brook, how the effect of ECP treatment on exercise-induced radionuclide defects improved in those patients, resolving those defects. Now, there was a MUST trial, MUST EECP trial, which showed reduction in time to ST segment depression and episodes of angina with improved long-term quality of life. And you can see that here in this graphic right there, showing the exercise duration improved and time to ST depression also improved in those patients. So ECP increased the time to exercise-induced ST segment depression, decreased the frequency of angina episodes. And beyond that, we can look at the International ECP Patient Registry. And in this registry, this is what I want you to pay attention to, that these were heart failure patients. They had functional class 3 or 4 disease, and Canadian class 3 or 4, and New York Heart Association class 2 and 3, and had multiple vessel disease, prior CABG. And you can see here that with that treatment, these patients were be able to move from class 3 and 4 down to class 1 and 2. And that's huge. I mean, if you don't remember anything else in my talk, remember this slide, because ECP can decrease angina and help heart failure patients. Now, Saran and Associates showed improved exercise tolerance, quality of life after ECP for patients with class 2 and 3 heart failure. Mike's in exercise capacity. So Dr. Feldman, one of my good friends, showed that ECP improved exercise tolerance in patients with chronic heart failure. So in my clinic here in Dubai, I'm doing a CPET analysis. So exercise with the MVO2 measurement, and similarly, they were looking at that the tolerance of exercise with chronic heart failure patients in ECP. I'm trying to speak fast so I can get done. So we honor your time. 35% of subjects in the ECP group and 25% of the control subjects increased exercise time by at least 60 seconds. So we see that ECP benefits the heart failure patient as well as the angina patients. So it's a safe, effective treatment for angina pectoris refractory to medical therapy. And the benefits of ECP include an improvement of functional status in more than 70% of patients. And the benefits are both short-term and long-term, as I told you about my uncle there in Oregon. Now, let's talk about endothelial dysfunction, because I want to take it home with COVID-19 and endothelial dysfunction. It's a key early event in atherogenesis. And endothelial dysfunction is seen in coronary artery disease, as we can see here in this slide, but also in COVID-19, it plays a very important role here. Nitric oxide is highly important with regard to COVID-19. COVID-19 begins with an acute respiratory distress, moves to all the vascular networks. And you see this platelet endothelial dysfunction and rapid life-threatening blood clotting. So SARS-CoV-2 is a thrombotic vascular disease. I tell patients this is a cardiovascular disease. It's not a pulmonary disease. Targeting endothelial cells, particularly evident in patients with cardiometabolic comorbidities, such as hypertension and endothelial dysfunction, just as we saw in the early days of COVID-19, when we weren't sure what was happening. Hallmark of endothelial dysfunction and thrombosis is suppressed endothelial nitric oxide synthase, or eNOS, and subsequent nitric oxide deficiency. So nitric oxide interferes with the interaction between coronavirus, the viral S protein, and its host receptor ACE2, so critical to prevent viral cellular entry. ECP can be a consideration for prevention and early treatment of endothelial dysfunction in the COVID-19 patient, beyond our heart failure patients in general. Mechanism of action is that of increasing nitric oxide production. So there are two levels of benefit: the reverse platelet endothelial dysfunction and associated thrombosis, and lowering the viral burden. We're going to see a little cartoon there in just a second. Ryan and associates showed that SARS-CoV-2 mediated endothelial dysfunction is the potential role of chronic oxidative stress. And we know about endothelial cells playing a key role in SARS-CoV-2 infection and inflammatory pathologies, just like I said, thrombosis, atherosclerosis, lung injury, and the mitochondria regulate the inflammatory pathways via the redox signaling. So through mitochondrial ROS, causing oxidative stress that initiates and exacerbates senescence or inflammation, chronic endothelial dysfunction, activating the feedback loops that perpetuate mitochondrial dysfunction. And this cartoon here nicely shows pulsatile shear stress as a backstop for COVID-19. So giving here the reasonings for using external counterpulsation. External counterpulsation provides a similar benefit as this gentle jogger model shown in this cartoon here, where we see the dichrotic notch for each aortic pulse wave improves with adding pulsations. And this is the same way that EECP works. And this was shown by Marvin and associates regarding the benefit of endothelial pulsatile shear stress in the COVID-19 patients. So we see increased production of adrenomedulin, activating G protein receptor, activating protein kinase A, activating eNOS. And then you have increased endothelial-derived nitric oxide. So endothelial pulsatile shear stress is important for increasing prostacyclin, TPA, superoxide dismutase, glutathione peroxidase, which I was going to ask Dr. Perrin about that, catalase, producing an anti-inflammatory endothelium phenotype. Remember, it's all about the inflammation, and we've heard it over and over in this great symposium here tonight. SARS-CoV-2 activates the endothelium monolayer loses its barrier function, and we see increased permeability. And reactive oxygen species, peroxynitrates, and NADPH are produced. Endothelial cell manifests procoagulant phenotype. So we are causing this hyperthrombotic state in multiple levels. And we can see interleukin 6 and interleukin 1, very important, just as Dr. Frazier talked about in his discussion. So PSS is a means to widely distribute beneficial endothelial-derived mediators. I'm almost done. So ECP doubles the number of pulses in the circulation, so producing this pulsatile shear stress, and that's what we need to increase the nitric oxide production. We can prevent viral replication, involved in non-cardiogenic pulmonary edema, endothelial dysfunction, all of the benefits shown there. So the take-home messages on my last slide is enhanced external counterpulsation is a valuable therapeutic alternative for patients with coronary disease, refractive angina, heart failure. 80% of patients who undergo ECP therapy have a positive clinical response, and this is associated with immediate increase in blood flow in various vascular beds, including the coronary arteries. So increasing blood flow translates into enhanced vascular shear stress, and that's a stimulus for endothelial production, releasing nitric oxide, key factor in endothelial homeostasis, and very important in the COVID-19 patient. Thank you very much.
Annie, thank you so much for this excellent talk, as usual, and very exciting and new findings, especially the COVID and EECP. We're going to start a question because your talk was the last talk, so maybe I'll start if I can ask you question about your talk, and then we'll go for other questions. How soon after patient admitted with COVID, let's say you have some, all kind of pulmonary or other issues in addition to heart failure, do you start ECP in that time, or you wait until the patient is more stable?
Right, so I have COVID patients.
Patient is not in CCU, patient is like in the floor, yeah.
Yes, absolutely. No. They go home, once they have stabilized with all our medical therapy, if they're in the ICU, get all of that done, get them home, and then we start the ECP therapy. So, it may be several weeks out, even 2 weeks would be okay. They just need to be COVID negative. We can bring them into the clinic. And
okay, great. So because I just want to be sure, it's not really acute treatment, it's chronic treatment after because patient discharge and stable.
Right, the effects are chronic. We're looking at the long hauler post-COVID syndrome, right? So
right, yeah. Excellent, thank you so much. There was a question from Dr. Itondi. The question was, what is the level of stem cell retention? I guess this doctor, is it Dr. Yahya Kiwan or Dr. Ren?
Yeah, well, I can start, but if Dr. Perrin is still around, yeah, I might start, but I'm sure he can complement my. Now, the issue with stem cell therapy are many. One of them is the route of injection, and what it was found that the intracoronary retention rate, there was a trial and a study after 18 hours. Only 4% of stem cells are retained inside the myocardium after intracoronary, compared to 19% of the stem cell after 18 hours are retained in the myocardium after subendocardial injections. So the retention rate is a big issue of intracoronary injection, and that's why most of the studies and the trials after that now moving into either subendocardial injections or intravenous infusions of stem cells. So in general, the retention rate is small and of short duration.
Thank you. Do we have any questions from panelists? Dr. Yasser, I see Dr. Yasser there. Do you have any questions or comment to the speakers?
Thank you, Dr. Halak. Yeah, thank you very much. So I'll start with Dr. Annie, because that's the last memory with us.
That's good.
Yeah, absolutely. So for ECP, we looked into another device called GECKO. Have you heard of this? A peripheral neuromuscular stimulator, a GECKO device?
I don't know of it. I think I've heard of it. Something similar.
It's a small device that, again, topical or percutaneous. You can it stimulates the peroneal nerve, and you can think theoretically that it improves the blood flow. So we, once I was in Western Canada, we did a study where we employed this device and measured the coronary flow, and it does improve. So that's why you have a good business in future in Dubai, because we will be having refractory angina patients and those we are not able to treat, and we're going to send it to you for ECP. And we do have many patients, they don't like stents, and it's better for them to get or go ahead with your ECP.
I have found that around the world, people, even though they love the Dr. Krazier's of the world and the Texas Heart Institutes of the world, you know, there are people who they don't want any intervention. So I think it's great that this conference showcases everything, you know, from the heart transplant, you know, all the way down to ECP. So thank you again for allowing me to present.
Dr. Krazier, a quick question, actually, an old question for cardiorenal syndrome. For the dopamine, renal dose dopamine for acute heart failure and derivative of creatinine, what's your take on that one?
Well, you know, as I mentioned in my presentation, all those clinical trials where inotropes were used, I'm talking about advanced heart failure. I'm talking about stage 3 heart failure.
Exactly. No hospitalized patient. No, we're talking about hospitalized patients.
Right. Yeah. So those drugs, obviously, as previous presenters mentioned, are of benefit, but they are of benefit only for temporary use. And then you have potential side effects or definite side effects, like you mentioned dopamine, and you're talking about you know, vasoconstriction, tachycardia, and all those factors that come with it. So it is of benefit, but it is of limited benefit, particularly in patients that have a significantly impaired renal function and significantly decreased cardiac output. I'm not convinced that any of the drug trials so far can address all the concerns and issues. Maybe it can help in certain acute stages, but definitely not in chronic stages.
Sure. Thank you.
Dr. Halak, I'll just take this opportunity to ask Prof. Krazier about this cardiorenal syndrome, if you may allow me.
Yep. Go ahead, please.
Yeah, so Prof, you mentioned that about 24 studies have been done and nothing has been successful so far. So we are seeing in our clinical practice that whenever we see cardiorenal patients or complex patients, so as a physician or in the practice, we have seen that people run away. They say that we don't have the therapy, so leave these patients for, let's say, for medical therapy and don't do any intervention. So from your wisdom, what can we do to attract people and say that, look, these are complex patients, although the evidence is not there, the trials have not shown us hard outcomes, but what can we do to manage these patients in a better way, like MDT approach, or do something to prevent? Can you guide us or teach us in this regard?
Right. You know, I think it was clearly mentioned by Dr. Les Miller and the other presenters that there are certain scenarios where really nothing works as far as medical therapy, and then we have to resort to catheter-based technologies. And also, we have discussed, as Dr. Jaggi George talked about, current devices that are available either in CIS format for acute type of interventional procedures or for temporary use. The problem with a lot of those devices that currently exist are that they have potential problems. They can be used only for a short period of time. For instance, like an Impella, you have to go through the aortic valve. There is always a potential risk of embolization, trauma to the structures that you have to go through. And then what is also a great concern and problem is that they are using very high RPMs, and you have a significant degree of hemolysis as well, you know, potential ischemia as far as lower extremities is concerned, and thrombogenesis and the risk of embolization as well. So I think that what Les Miller and what I have mentioned, there are, you know, 4 or 5 or more devices that are currently undergoing clinical trial to address this problem and to resolve this problem by either not placing them across the aortic valve, where you can reduce the RPMs dramatically to, let's say, less than 5,000 RPMs, where minimal or no hemolysis can occur, and they are lower in profile and therefore less risky as far as ischemia is concerned. And they have shown in preliminary stages very good durability. So I think there is a light at the end of the tunnel. And what we have also seen from Les Miller's presentation, there is a chronic device that's currently in the process of being evaluated that can be left there for a longer period of time. I'm talking about weeks or months or longer, either as a, you know, transition to some other definitive procedures or treatments, or for permanent chronic use. So I think I'm quite optimistic. There are devices on the arterial side, there are devices on the venous side that can improve those conditions. So I think in the next 2 or 3 years, we will see significant improvement to address this problem when medical therapy does not work or is suboptimal as far as our patients are concerned with heart failure.
Yeah, I think making things more complicated is the patient with a heart failure come in with an ischemic event, non-ST elevation, and you have renal failure, and you have to do angiogram and make things much more even complicated. So probably those devices to get a little bit of hemodynamic support maybe bridge the renal function to go through over the toxic effect of the dye. So probably, I don't know if there is a trial to have those devices put prophylactically before the contrast exposure to decrease the chance of damage of renal function in patients who have already heart failure.
Yeah, you're absolutely right, Omar, because with aortics in the first in man and the early stages of trial in the similar with second heart assist device and also with the Raytheon device, we have seen that actually the renal function improves, and during interventions, I'm talking about coronary interventions, the renal flow improves, the creatinine improves or it's stable, even in a short period of time during the intervention. But definitely with a longer period of time of use. So we're quite optimistic that they will work in improving renal function and preserving renal function during intervention and also in heart failure without any intervention.
Exactly. Okay, I don't know if we have any questions, any more questions. Otherwise, any other questions from the panel or from anybody from audience? Probably everything was so clear, no questions. Okay, I think it was a wonderful meeting. It was really great. And definitely, I learned a lot from this new technology, a new way to look at the heart failure, new medication, and so on. It was really very interesting symposium. And definitely looking forward to have probably update of this particular symposium in the original 40S on February 2022. So probably we can have updated talks from what we have today for the next meeting. And definitely we would love to have everybody with us in that February 2022. And we hope that we'll be able to meet again in Dubai. Inshallah.
We hope so. We hope
yeah.
so.
Dr. Krieger, last word you want to say?
Yeah, Omar, thank you very much for your friendship, for your partnership, for really moving forward with this concept and being persistent, even at the time of COVID. And it was a pleasure once again to work with you on this project. And thank you, Annie, and all the other participants, all the faculty and panelists. We are very pleased that this was another successful event of 4Ts. So we will be in touch and we'll see you in the future. Thank
Inshallah, inshallah. Thank you so much.
Thank you.
Good night, everybody. Thank you.
Bye-bye.
Bye-bye. Thank you.